faculty members, students, undergrad, post-graduation, and the general practitioner. I welcome you all on this online platform for this fifth session of live surgery from Government Dental College and Hospital, Mumbai, Department of Conservative Dentistry and Endodontics. Today we'll be presenting a case on restorative procedures. Before this, we have done 4 live surgeries, which are mainly focusing on surgeries. Today's patient or today's demonstration will be more focusing on more aesthetic rehabilitation of a patient. So I welcome you all the delegates and I also wish you in advance happy Independence Day to all. And today we have distinguished guests also for the live demonstration as well as the question answer session as well as the treatment planning. We have Dean ma'am also here with us. So now I hand over, and this broadcast is almost going throughout 18 cities throughout India, all the corners of India, and around 6 places where it is live placed on the screen so that everybody is going to see in the different colleges. So that is something which is need to be mentioned here. So henceforward, I'll hand over the mic to Dr. Bala, who will introduce the speakers and further proceedings. Bala, please welcome.
A very good morning to one and all. We're very happy that all of you have been able to register for our program, and y'all are all live over here. So first, we'll start with our first chief guest, that is Dr. Ajit Shaligram. He completed his BDS in 1995 from Bombay University and MDS from GDC Aurangabad in 2003. He has been having his private practice since 1995, and he's primarily focused, and his field of specialization and interest has been on smear layer, endodontic retreatment, microscopic enhanced dentistry, as well as continuing education. Sir has also been the past president for Rotary Club of Thane, as well as he's started the fellowship program in endodontics in IDA under the MUHS in 2018. We welcome you, sir. Okay. Shrikant is going to read the biographs to announce. I request Dr. Shrikant to introduce him. And facilitate करने के लिए उनका introduction करने के लिए प्रेजेंट बुलाएं. जी. Our next subject expert for today is Dr. Mayank Doshi. Dr. Nishikant would be introducing and felicitating sir. So please come on. Thanks.
Okay, so good morning all. Welcome to the Dentix Dental Education for the Next Gen Treatment Expert. This is our educational initiative in association with Department of Conservative Dentistry and Endodontics, Government Dental College and Hospital, Mumbai. So today's focus of session is ceramic single visit aesthetic restoration surgery. This is a revolutionary approach that combines precision, speed and aesthetic to meet ever evolving demands of the modern dentistry. During this live procedure, you will witness the complex workflow of ceramic restoration that will be performed by the experts from the tooth preparation to the final placement. So this session will aims at demonstrate how digital dentistry and advanced material can transform patient experience and clinical efficiency. So for today's session, we have an expert surgeon, Dr. Abrar Syed, Professor and Head of Department of Conservative Dentistry and Endodontics, GDC Mumbai. Joining us with the expert, Dr. Mayank Joshi, cosmetic dentist and implantologist, Mumbai. Dr. Ajit Shaligram, endodontic surgeon from Mumbai. So first I will introduce our expert surgeon, Dr. Abrar Syed. So Dr. Abrar Syed is a professor and head of Department of Conservative Dentistry and Endodontics at Government Dental College, Mumbai. Sir has over 2 decades of experience in clinical teaching, and he has been performing live.
Excuse me, sir. Requesting you to please discontinue just for a while before we felicitate and honor our subject expert today. You can read my biodata later. Thank you, sir. Thank you.
Yeah, okay,
We'll invite you whenever there is introduction needed. Thank you.
okay.
We will coordinate because I'm so sorry for the viewers. We are at different locations, so there is a bit of coordination here.
Thank you very much, sir. So today we have Dr. Resham Pakmode also with us. She has been a very viable person in the field of periodontology, and she's currently the assistant professor at JJ Medical College, Government Medical College, Mumbai. She is an excellent periodontist, and today she will be giving us a live demonstration on the various suturing techniques and how to close up the incision that are going to be there. So her information and her knowledge is going to be very valuable today. We felicitate you, ma'am, and thank you very much for coming. Lastly, we have a CDE observer for today, Dr. Nikhil Khandge, who works as a practitioner at Mulund. He has been focusing primarily on aesthetic dentistry as well as lasers, and he's an excellent oral and maxillofacial implantologist. We welcome you, sir. Thank you so much for being here. Before we start, I would really like to extend our greatest and most humblest gratitude to our Honorable Dean Ma'am, without whom none of this would have been possible. Her support has been extensive and she's always been our backbone and she's held the fort for us. So thank you so much, ma'am, for being here. And thank you for always lending us your support and your words of wisdom. Thank you very much.
I request Dean ma'am to say a few words.
Very good morning. At the onset, I would like to appreciate the zeal and enthusiasm of the head of the Department of Conservative Dentistry, as well as the whole team of Conservative Dentistry and Endodontics of GDC Mumbai. It is the fifth live session of this Department of Continuing Dental Education. And the zeal with or the enthusiasm with all participants have registered, it's crossed 3,000. I think they need a round of applause. So keep continuing the education, imparting education. You also learn and let others also learn. Thank you. Wish you all the best.
Thank you so much, ma'am. Our gratitude to the Department of Prosthetic Dentistry, as this case right in the beginning, all of us have seen that it is an interdisciplinary approach. Let me remind everyone, the participants who have registered in the previous program, this is the same case that we had operated on 21st of February 2025 with an interdisciplinary approach with two of oral surgeons working with us, a periodontist working with us that time, and two of us, P.D. Joshi sir and myself from Conservative. So 6 of us were simultaneously working on the same patient and we could salvage those teeth. And now the healing is complete. Now the prosthetic people have been requested to help us and support us. After a lot of academic deliberations yesterday about the clinical decision making, it has turned out to be more over a prosthetically oriented case than conservative. So Our thankfulness to the Department of Prostate Dentistry, Dr. Aarti Godeswar, Professor and Head Department of Prostate Dentistry, GDCNH Mumbai, and along with her, we have Dr. Raj Salvi here, who has completed post-graduation from the same institute, and young and budding prosthodontist. We welcome you both. Please come. Please come. Manoj sir, I request Dr. Manoj sir to felicitate both of them. Thank you so much, Dr. Aarti. I request Sangeeta madam to felicitate Dr. Raj sir. देऊन टाक ना, देऊन टाक, देऊन टाक. आहेत, आहेत. हम्म, हम्म. अरे the small inaugural function is declared as complete. Thank you so much, everyone, for being a part of this team. Now, let's begin with the clinical work. Thank you so much. Looking forward to each one of you for positive questions, for support, for any reasoning and logics that can put forth. This is purely an academic platform. So we request all of you to participate, to watch. And now we will be presenting you the case. And during case presentations, our chat box is open. So all of you, please post your questions, give your suggestions. If you feel that your evidence that you have come across in the literature differs from what we are following here, correct our path, guide us, have nice academic exchange. Thank you so much. I'll present the case in a while, then start the clinical work. Thank you.
Yeah, before we start the case presentation, we encourage all participants and the dental surgeon for this to make the session interactive. You are free to post your question in the chat box related to the procedure during the live surgery. So our expert will address all the question during the procedure and the question answer segment.
Welcome back again. Thank you so much for joining us. Am I audible and online?
Yeah, sir, you are audible.
Okay, thank you. So at the outset, before we start the presentation of the case, I would like to thank Dr. PD sir for his unconditional support forever whenever he comes to us. Unfortunately, sir could not be with us today. May I invite sir through a link online? Audiovisuals, can you please pull sir here online? Take him online, please. Sir has been a very senior faculty in our department since 2009, a very long tenure, a selfless service. First time ever, sir is not here physically present for the program. Is sir available here right now? Yeah. Sir, over to you.
Thank
We
you.
seek your blessing, sir. Please a few words here.
Thank you, Dr. Abrar, and all the best for this program today. I wish I was there in person, but my heart is there in person with you. So please go ahead and do
Thank
it. I'm sure Dr. Ajit Shaligram and Dr. Who else has joined? Dr.
Mayank.
Dr. Mayank Doshi.
Dr. Mayank Doshi.
Both of them will do a very good job, and I hope all the students will also and participants will enjoy this program today. Thank you for allowing me to join from my place. I'm in my clinic, and you can see I'm here. So whenever you need me to answer any question, I'll be there.
Slide changer. Thank you so much, sir.
Thank you.
To the case now. We are working together, myself, Aarti, and Dr. Raj. This was the case to go with initially. This is a 23 years old patient, the then 23, now is 24, reported to us with a history of trauma for 1212 in the upper arch. No obvious extraoral facial deformity was seen as a result of trauma. Intraocclusal view indicated multiple fractures. Side views do not indicate any pathology as such. Intraoral sinus tracts were observed with both the central incisors. Lateral view, occlusion can be seen. Posterior occlusion is good. The incisal guidance appears to be steeper in this case. Hence the fractures. Occlusal view indicates that the fracture lines in almost all of these teeth go much apical as compared to more cervical as compared to what they appear on the facial aspect of the teeth, and there is uncomplicated crown and root fracture with one of the centrals and at least class 3 in all three of the interiors except one where there is at least class 2 present. If you see the arch, shape of the arch is U here, and the lower arch appears to be more squarish with canine having a rotation. So this leads to excessive forces. When the disocclusion happens, this one canine throws an entire arch side onto a groove function. So that's quite deleterious for the incisors to happen. That must be a primary cause of why this broke this way during the trauma. That time when we saw it in this manner. These were the fracture line intraoral periapical radiograph showing fracture to be oblique on this side and a horizontal fracture this side with fragment separation. If it is appearing so well on the radiograph, that means there is quite a lot of separation there. And if you see there is periapical widening in one root, and there is no obvious widening in this root even after 8 months. So various discussions happened at those time when we did this case online on 21st of February. And finally, we decided to intervene with surgical intervention, extracting both the root pieces. This is a surgery. Click. Preoperative prep, anesthesia, incision. This whole video is available online. It's session 2, case number 4, 21st of February 2025. Now we open the apex, Microscopically, we are hunting because what you see is only the blood that time, the vertical fracture, splinter from the palatal aspect being removed, irrigation, intraoral, canal irrigation coming out from the apex. On the left central incisor, extracting the root piece was easy. Sorry, on the right it was easy. On the left side, we found it quite a task to locate it because of there's no color difference in the dentine and this tooth. Ultimately, as you saw, we have injected a dye in that surgical defect to stain the periodontal ligament and then identify the root piece with a microscope. This is how the obturation was done. Yeah, this is the dye being injected. And that's the line of the PDL. That's how we recognize the root piece and finally extracted. Shape the root. Remaining root piece. India ink. Now located the piece which was towards the nose. This was the root piece as out. Periapical curettage, irrigation, and we have a micro mirror placed in the apex for confinement, drying of the canal. We have tried the size of that as a stopping agent. Preparing the cavity to receive the restoration in the canal. This we keep a piece of gauze in the apex to prevent overfilling and smearing of the entire material into the cavity. Plugger is being used. This is what is giving us a apical stop, micro mirror, opposite end. Drying of the canal, putty MTA being deposited in the canal, and a plugger being used for compaction. This is the final outcome. This is putty bone, followed by guided tissue regeneration because of the defect. If you see both the teeth appear to be having a dehiscence here, that's because of the TFO and sutured. This is what was done approximately 6 months back. Now the entire surgical lesion has healed, the bone defect has disappeared, and we have current. This is how we have done it with the putty and confining effect of micro mirror. We had to do it this way. You see the instrument and you see the putty here. This is the picture today. It shows good tissue healing, all gingival inflammation gone, sinus tracts disappeared. And now this, if you see the tooth, you have an entire length with difference, because we call the fractures to be horizontal and oblique depending on the two-dimensional picture on the radiograph. However, we calculate the crown root ratio depending on those values. This sagittal view indicates totally different situation. Is almost 4 millimeter difference between the palatal wall of the root that we have and the buccal wall of the root that we have. So it was meticulously operated using, we resected a little bit of this and then we placed a mirror down here. We had created a landing platform with instrument here, confining effect for the MTA, and then we injected the MTA. You can see the confining effect here. This way, and a specific retrograde zirconium nitrile tip was used to prepare it in the same direction without compromising the whole root. So we have a palatal wall which is compromised. We did not compromise much on the buccal wall. Hence we went here and then we prepared it. If you can see that the outer funneling here. Okay, so now the healing is complete. The entire lesion is nicely healed. This is a pre-op and post-op CBCT. This looks fine. See, this is the broken fragment that we have removed and now the healing is complete. This was done pre-operatively. This same slide I had shown you on 21st of February 2025. Now we need to plan this restorative phase of the treatment of the same case. So what we are having here is a scan, intraoral scan, preoperative scan of the patient, and we need to go in for a preoperative designing of smile. So we will be superimposing the lower impression and the occlusion, and this is a mock-up, digital mock-up of the case. May I have the cast? Upper and lower cast first with the base. Yeah. This is the occlusion. Can you focus on this a little bit? Yeah. With the mock-up. This is pre-op, and this is the 3D print of the same mock-up, digital mock-up. So this is how we plan to do it. When I go on to the patient for preparation, I will show you the problem that we have with this. The form of the tooth is being changed here a little bit. Cervical narrowing would be preferred depending on the pre-op. We have planned a stent also in case we need. This is how we need to superimpose here. Beta, you're playing the video? Yes. The photograph being superimposed onto the scan. This process, I'll take you online on the software itself and then again take it in detail. So from this photograph of the patient before trauma that patient provided us with, we have used that as a reference. So amalgamated three, the intraoral and the preoperative that the patient gave us, and the scan that we gave, and the AI that works for the software naturally for suggestions. These are all the steps that I'm going to demonstrate to you one by one just now. Lip line, horizontal plane, midline, eyes to be taken as the reference so that the distortion is taken care of. This is the suggestion using AI by the software. Software already has a lot of algorithms into it on which it works. Superimposition. It gives you a form, but final decision is of the clinician because you know the nitty-gritty of the clinical situation. It will use software algorithms to use. Okay, and if you see what it is suggesting here, that I'll show you in the software better. Better not speak here. We are adjusting and superimposing a possible future crown with anterior visibility, managing length. That manager manages the proportion. You see that? This is digital mock-up, almost ready. We use these softwares and in-clinic CAD/CAM restorations we make since 2011, but this is a different software we are trying out this year. This is AutoCAD, and Mr. Hoshiar Singh is going to help us with that, the technician who has been using this for years together. So maybe connect to the screen of the laptop. Yeah, come. Which desk? There is a charging point behind the screen. So get him charged. No signal. Okay. Audio. पुष्कर सिंह साहब के पास एक बताने के लिए क्या कर रहे हो सॉफ्टवेयर पे? मैम आप बताओगे? हाँ चलो। We are started designing pre-operative digital smile using ExoCAD. Sorry, I took a wrong name last time when I spoke. I said AutoCAD. I'm so sorry. It's ExoCAD software. This is the basic format for patient registration and records. Enter anything fast. Yeah. The doctor's name and the patient's name, technician's details. Yeah. Selecting the teeth involved. Going to the options of selection of material. We are right now selecting zirconia, which we'll ultimately be doing today. Anterior 4 teeth have been selected on the software screen, and automatically it has detected that upper 4 restorations are being made. And 3 dots that you see on the top, which are green in color, indicate that these 4 units are being fabricated individually. We theoretically never ever recommend joining all these units, not to alter physiologic mobility of teeth against each other. Proceeding ahead, after registration process and selection of teeth, we go to designing. I request Aarti ma'am to take it up from here.
Thank you, Abrar sir. We are going in for designing. So we're designing the upper one first, the maxillary arch.
Now what happens is, normally sir,
And we're taking the lower one.
इसमें किसी को
Just
question
take the
आएंगे, आपको
bite for
बहुत
that.
question
Now
आते
we
हैं
have
अभी
come
तक.
to the maxillary one. We
question
can
आए.
see the
Question आएंगे ना,
this
they
is
will
the
be
zero
posed to
view
me
that we are
or
supposed
posed
to
to you.
select. Occlusal view, which we are going to select. You can see the incisor edge which are fractured. This is superimposition of the mandibular one. We are taking the image of the patient now. And we're going to superimpose that image over here. So on the right side, we have an intraoral, extraoral view of the patient with a retracted cheek. You have to make sure that the head tilt of the patient and the tilt in which the scanning has been done is exactly in the same. We are selecting certain points on this so that superimposition is easier. Taken different 2 colors for the selecting the points. We are superimposing the image of the patient and the bite that we had taken. This is how it appears. Both the maxillary and the mandibular one scanning that was done has been superimposed on the patient's face now. Now we are going to select the normal smile. So this is what appears. This is the preoperative view right now. We are going to mark points on the eye, the pupils, so that the exact positioning of the intraoral alignment can be done. We're selecting the lip position and the smile position. This is a AI generated software. You can easily position the lip position. We are going in for the acquisition now. So AI automatically detects where the positioning is. You can easily position the XY axis of the patient's head, as well as the midline, the facial midline. This was the lip position that we had recorded with the previous image. We've coincided with the facial midline. Now, because we had already selected the zirconia, now we are going to select the size or the shape of the teeth. We are going in for a tapered one. No, that was ovoid. To go the other one. This one. Yeah. So we have selected the tapered size because the patient's face, if you observe, it is more tapered, and he had shared with us pre-operative before all these teeth got fractured. We had seen the photo, and that also in that picture, he had more tapered teeth. So we have selected that. We are arranging that according to the position of the teeth that is there pre-operatively. We can take the teeth up or down so that the smile line can be arranged. Individual teeth position can be adjusted. The center incisor has gone more up. Yeah. So we can take, if you can easily observe, we can take the incisal edge up or down. We can make the size of the teeth small. We can enlarge the size depending on the face. The patient's right side lateral needs to be adjusted a little bit. Yes, that's fine. So we can adjust the teeth position, alignment in all X, Y, and Z axis.
Can we check here?
Yes. We'll go ahead and check it in the pre-op. In the patients, we have already simulated on the patient's face now. I think we can bring the lateral incisor slightly, the level of the teeth slightly more down.
Down.
Down. Slightly down. We're going more up. We need to take it more down.
Okay. Sorry.
Yes.
This one also. It's okay, perfect. This one. Look at it.
We can take this one a slightly more down. That's it. The preoperative view that we had, the picture of the patient's face, he had the central and lateral alignment nearly at the same level. We will try to replicate it. If we find some interferences or something intraorally, we can always adjust that. So you can see the pre-op fractured and the post-op along with the teeth. So this is a very good tool to show it to the patient that this is how the teeth are going to look after the placements of the caps that have been done. We can always select the shade and everything depending on the shade tab that we have. This is going more brighter. The hue chroma values and everything can be set in. We'll go in for an A2 shade. Okay, so we'll go for A1. Okay, so this is the pre-op scanning that has been done. All tinting and everything is possible out here. And we can show this image to the patient. We can even get it 3D printed so that we have the models ready with us before we start with the clinical procedure. So we have a full PDF which can be even given it to the patient so that they will come to know what all exactly is going to happen, what was the preoperative view, what was the postoperative view, how the teeth are going to look. So this is a very good tool to explain to the patient and to convince the patient about what exactly, how it is going to be looking. It is not something which is left to the imagination now. This is what you're going to, which is going to be visible after the whole procedure. Thank you so very much. I request Abrar sir to just take over now. We can start with the clinical procedure.
We are almost ready for starting the clinical work. Just give us, I think, 3 to 5 minutes. We will immediately resume the video. Thank you. The questions here. Okay, the first question is, why crowns, not composites? So I request Dr. Ajit Saligram sir to throw light on this question. So please, to be here. Hand mic. Sir, on the side, please. Yeah. You be there.
It is an individual choice whether to have a crown or a composite. Considering the longevity that we want out here, considering that the uniformity that we want here, the proportion that we are looking at,
Microscope.
especially considering that it is bilateral, the matching has to be very precise.
Block here.
At a lot of time, indirect restoration is going to be much better as compared, a direct restoration is going to be much better than compared to the composite. So out here we would look for lab report, we would look for a better match, we would look for a better harmony out here, and that is why we would choose a crown or a lab fabricated prosthesis instead of a chairside prosthesis that we might have done. We might do that especially if we got just a single tooth, or matching is not that important, bilateral it is not that important, then we would do a composite. Otherwise, it might be better to do a restoration which is lab fabricated. Yeah.
Thank you so much, sir. The next question is, why crowns, full crowns, and why are we not using laminates in this case? I would request Dr. Mayank Doshi, sir, to come and enlighten us about the same.
Yeah, hi. If you would have noticed the preoperative situation of this patient, the patient is very young. The occlusion is not in our favor and has had palatal fractures extending almost till the cervical area. So the possibility of doing a veneer would eventually turn out to be almost like a 3/4 wraparound or almost like a full coverage veneer, which would eventually turn into a crown. So from the longevity point of view of this patient, if you consider covering the fractured part that is there on the palatal part, you would eventually have almost like a 3/4 coverage of your veneer. So you might as well give a crown to the patient and, have a minimally invasive procedure over there. I hope that answers the question. Thank you.
Thank you so much, sir. The next question is, what are the treatment options available if the patient cannot afford CAD/CAM restorations?
Yeah, thank you for the question. And a lot of other questions have piled up. Dr. Kishore sir is having a lot of lineup here, but considering the time constraint, we will take them up as we start the procedure. And the last question somebody has posed here is, why not composite? Sorry. Yeah, what are the treatment options available in case the patient cannot afford a CAD/CAM crown? First of all clinical decisions are made by the clinician depending on the practical feasibility. Whatever in academic institution we teach is whatever is the basic and what are the current alternatives. Here in this case, if I may have the photo, as I have given you a detailed presentation, the incisal guidance is very steep, the forces are very high. All the fracture lines have gone palatally almost to the cervical 1/3, practically touching the equigingival length. So if you have such a slanting fracture line and such a deleterious force coming from the lower arch, and the incisal guidance so steep, composite may not have long survival. So if I want to obtain optimal aesthetic result, the best possible aesthetic result, I need to give crowns, in this case, having length slightly longer than the lower incisors. If you see in this case, what we plan in a composite, if at all we have to do a composite, I cannot gain that length because I need to give an edge to edge or a slightly short bite. So that may not give me an aesthetic result. As the question poses, if patient can't afford, if there's no affordability, definitely composite is an option with two things in mind. That there can be a catastrophic failure of debond completely because it doesn't have a resistance form. Though the bonding surface is quite good available, a very wide surface is available, C factor is favorable, we do not have forces and occlusion onto our side here. Okay, if you want to give patient a much affordable option, composite is definitely option, but you slightly compromise on the aesthetics there. Okay, that I think that answers the question. Second question was other alternative. Other alternative for treatment here is we could have taken laminate on the left lateral incisor. But if you see left lateral incisor is a class 4 fracture, if you see it from the facial aspect, the moment you see with an indirect vision with a mirror, the fracture line has covered entire lingual surface and is going subgingival there. So that's a very bad case for a laminate. It will debond very fast the moment it comes to any kind of a force, acute trauma. So finally, we concluded that it requires full crown restoration for longevity as well as developing resistance form to any further fractures and to build the smile in proportion because the patient is young and demanding, and you saw the preoperative picture of the patient, so good looking central incisors they were before they broke. So if you want to restore them to the length, see, one methodology of treatment introduced in the science or in the clinics or in the market does not refute and eliminate the age old techniques which are conventional, which are time tested. We here, being an academic institution, we focus on what's the next generation will face. So we prepare our students and learners for something that they are going to do in their futures. And we want to keep our knowledge updated. Thank you so much for your participation. We start with the clinical work here. Thank you.
Thank you very much, sir.
Before we start the clinical procedure, I request our subject experts to give concluding remarks for the proceedings of the day, whatever has taken there, please. Hand over the mic to both of them, please.
It is indeed creditable that such a workshop is being arranged and it reaches out to such a lot of people. So the department here of the conservative dentistry and endodontics at GDC under the guidance of Dr. Abrar, they are doing a fabulous job. It is important to integrate the technology today with whatever materials that are available. Everything is synced up so beautifully. The latest technologies are in show. The newest equipments are on. Everything that needs to be done is being done so flawlessly and perfectly. It's really a appreciable thing. Mayank, you would like to add something?
I mean, it's amazing to have such a kind of, workshop being arranged at that level for each and everyone, where anyone can sit anywhere in their practice or hometown and they have access to such amazing stuff being done. I wish, during our dentistry days, such things were available. But I think whoever is seeing this should actually, take maximum use of this and spread the word so that more and more people from our country benefit, of this initiative that is taken care of. Thank you very much.
This entire event is in-house event happening in the department with the infrastructure given by the government of Maharashtra. We are government institution, Government Dental College and Hospital, Mumbai, and Department of Conservative Dentistry and Endodontics. So this is purely a government facility working in favor of larger interest of the profession of the learners. Learners can be student practitioners or people across the specialties. We are not proving a point here. We are trying to do some work in the best interest of the patient and the learners. So your questions, your suggestions, your criticism is all welcome. So kindly give your suggestions, okay? And ensure that the questions are posed related to today's topic and the subject, okay? We have received a couple of questions about the third molar teeth. So let's keep them apart. Thank you so much. Audio is on. Diopter settings बघितले का? आयपीसच्या ए डायोप्टर सेटिंग चेक कर. डायोप्टर सेटिंग रे एक वर पाहिजे. +1 +1 वर डायोप्टर सेटिंग्स ठेव मायक्रोस्कोपच्या बाजूला बेटा मी करतो. हेड सपोर्ट थोडंसं डोकं वरती घ्या दादा. आता आता डोकं टेकतं व्यवस्थित. पेशन्स फिक्स मराठी ना. किशोर सर इज अराउंड. सरांना बोलवा. चष्मा कोणीतरी उचलायला लागेल. दादा बरं वाटतंय ना. ठीक आहे ना. तुम्ही व्हाइट स्पॉट क्यों आ रहा है रे. Just see if it is coming online also, the white spot. Hmm?
Light source.
No, sir. No. No, students have used it. They have some material. No. Students have. Change the microscope, please. No, sir. Somebody has splashed some material on the surface of the ऑब्जेक्टिव्हच्या नंतर जो हे असतो ना ग्लास असतो ना तिथे ना कोणीतरी here. बंद करा दादा, बंद करा. Take it to a higher magnification. For the new joinees here, our microscope is going to be out of focus when I'm not looking into the work. So when I am not looking through the scope, you will not see it properly and it will be thrown out of focus. That's a natural phenomenon with seeing it with a microscope. It does provide you a facility. See, I'm going on higher magnification. You will see an enormous amount of detailing. Okay. But the sad point here is when I'm not working, you will not see anything. There is a tongue thrust here. And this is the right lateral incisor in focus I've taken. Okay. So to begin with, थोडंसं खाली पहा असं बस. Very good. As I am a conservative person here, working under the guidance of the prosto people here, I usually tend to first mark it with a pencil so that I don't mistake. We'll start with the lateral incisor tooth preparation. आकार दादा थोड़ा सा, हाँ. We'll start with this tooth. I still follow the same technique as we used to follow in the student life. Trying to project it with 0 degree. ये वो मेरा एक गेस्ट आया यूएस से, उनको खाली हाय हेलो करके बिठा दो किधर. They've come from New York to see. We go here. And here. एअर रोटर चालतंय ना आपलं. कंप्रेसर ऑन केलंय का? सक्शन द्या आम्हाला कोणीतरी. थोडंसं खाली पाहायचं दादा. हां. I'm very thankful to everyone who's online. आता नाही होणार. आता नाही होणार. The screen was moving because we were preparing different angulation. Every time I prepare myself, initially I was focusing the central incisor with a straight on projection. As the tooth is छोड़ून दे बेटा, मी करतो ते. As the tooth is rotated, now I am giving it an angle of viewing from the, as if you are watching it from the left side, okay? Though I am on the right side of the patient, microscope gives you that facility. नाही, that will come. आपली हे जे तुटलंय सर, हां ते तुटलंय सिग्नल. Ajit sir, the moment I go out of focus or something, please let me know. Huh? Both of you please be seated. Will take long time. हा करा दादा. हा रिलॅक्स. एकदम निवांत राहा. पाणी थोडं कमी कर रे. जास्त आहे बेटा. कमी कर. बंद झालं. हा. I'm working on 25x magnification. Why the screen is flickering this time? Oh, ठीक है. You are viewing this preparation at 25x magnification. This is a huge magnification that we are looking at it as. So now I'll be relieving the distal contact. Point is not to touch the adjacent tooth when we work. I hope we are doing justice to the preparation. SF41. I'm using a diamond point SF41 for the preparation. Now I'll make the parietal preparation here. I have kept the margin equigingival right now. I might take it later at the finishing stage to subgingival. Okay. Microscope is like mirror, it doesn't hide any truth. So whatever shortfalls and mistake that I commit is going to enlarge it to 25 times and show it to you. हाँ करा मोठा दादा हाँ view has to be changed. Open this. Long taper with round end. Long thick taper with round end. Lock it up. Lock it up. This way, beta. Should not be moving. Can I have a new mirror? The mirror is having a scratch. हाँ ठीक है बेटा. Long taper with thin, long taper with round end.
We have another question. The question is, why are we using zirconia crowns or zirconia as a material of choice in place of Emax?
So in case of Emax crowns, there is more chances of the crowns to get fractured because the patient has got some amount of a deep bite and there will be a very big thickness of the Emax crowns. So in this case, and if you see, observe the remaining teeth, if the patient would have had more translucency in the remaining teeth, then we would have gone for something which will provide us more translucency in our crowns. So in that case, Emax can come into a picture, or else what we could have gone is we could have gone a zirconia coping, and on top of that, we could have provided with a layering. But because the teeth are opaque in picture, we are not looking in for over here, we are not looking out for translucency much. We have even observed the lower incisors, even the lower incisors, incisal edge is not much translucent. If there would have been slight amount of translucency there, then we could have gone for zirconia coping and then a layering on top of it.
Thank you very much, ma'am. The next question is, if we are rehabilitating the patient with crowns, and if there is some amount of mobility late in general, if the patient is still having mobility, how do you apply a fiber splint on the crowns for such patients? Or how do you apply a fiber splint in general to prevent mobility in such patients?
In that case, rather than providing a splint kind of a thing, what we can do is we can have something which is called like an ASICS kind of a retainer that can be given, which will provide us a splinting effect of all of them. Or else what we can do is we will have to add, it is difficult to etch the zirconia. So because of that, we cannot have some kind of a fiber post or some banding or something that can be done. It is better to give in an ASICS retainer for this kind of thing.
Thank you very much, ma'am. We have another question. For horizontal root fractures, is it recommended to have veneers or crowns, or rather, how do we rehabilitate these patients?
So when you have got a fracture line, which is specifically only the incisal edges, little bit more than that, probably you can think about veneers, because veneers will not be taking the so much of, they will not provide you that much support for the teeth, and they will not be very much retentive in a long run. So if you've got a fracture, which is more of an oblique in such case, which has already been seen over here, in these cases, you cannot go ahead and give a veneer because specifically for the maxillary anteriors, which will have all the lateral brunch more in the anterior protrusive direction. So in those cases, the veneers will not last. It is better to go in for a full coverage crown as compared to veneers.
Thank you very much, ma'am.
Now, we need to see the preparation is initial preparation is complete before the finishing stage of the lateral incisor. What I assume here is the clinical length available is very less. So we have to go for some additional coronal support. So in that case, considering the bite, we would like to go for a post-encore. I would like to have comments from Aarti madam about it. Ma'am, shall I proceed with the post-encore or this suffices? This structure suffices? Open kara dada, tond open kara, halka band kara tha, band kara. Actually, it's a borderline case. You might get away with a composite also mostly.
Little bit amount of composite also would suffice, but if we have a straight kind of a preparation, even if we go ahead with the same way it is there right now, also will suffice, because our brunts are going to go. Only thing we have to take care about is in the final restoration, you will not have any occlusal forces which will be coming on the lateral incisor. If you avoid those occlusal contacts on the lateral incisor, that will be sufficient enough. You don't need to go in for a post-encore in that case.
Okay. So I would like to invite expert comments on this. So shall I proceed with the post-encore in this case, or we can get away easily with?
Yeah, even I feel we have sufficient amount of ferrule available where we can, just add a little bit of composite to add on to the stump length, and which will provide the necessary resistance and retention form to the crown.
Thank you. Ajit sir, your comments, please.
Yeah, I don't think it would really be justified to again have a post here. Not really needed. And in fact, it would not really help in any way. So you would just carry on with the complete restorations without a post.
The view is not great on the screen actually. दादा थोडंसं हलू नका तुम्ही आता अजिबात नका हलू. लॉक द स्कोप. कोण आहे? लॉक द स्कोप. हां, हलू नको बेटा, हलवू नकोस. हां, लॉक कर. हां, चला स्टार्ट करू. Line of draw is this. Same line of draw to be used here.
We have another question. So the question is, for Emacs, the preparation needs to be much more thinner. For example, for zirconia, we need at least 2 mm of clearance, but for Emacs, we can at least need a little more lesser clearance. So why not? Would it be better to save whatever remaining tooth structure is there as compared to trimming it down?
So the question is again the same way. Our incisor edges are already fractured. So if you're talking about clearance and everything, it's usually the 2 mm reduction is there in the incisor edges. Now the incisor edges of all these teeth are already fractured. So the remaining tooth stump, that will not sustain for your Emacs crowns. And it is better to go in for a zirconia. As I suggested, you can either go for full zirconia or you can go for zirconia with an Emacs layering depending upon the translucency of the remaining teeth.
Thank you very much, ma'am.
And we are milling out restoration. So we can't mill in two materials. We are going to show you the workflow of the entire digital single visit CAN-CAM material. I request Team Prosthetics to see whether I'm angulating myself properly. For path of insertion of the teeth. Dr. Raj, Dr. Aarti, please have a look at it. Correct, no? Because teeth are angulated. Yeah, I'll show, sir. Once. तोंड उघडा दादा थोडस. हा. हा करा दादा. हा. हा करा तोंड उघडा. What happened? What happened, बेटा? It doesn't matter. I can handle both mirrors, बेटा. Okay. I know. This, na? No, it's not the problem with the mirror. It's indirect vision, no? The microscope has to be set on a different location so that I can demonstrate. If I would have worked, I would have worked on each surface together. All interiors and then all facial surfaces and then all. Yeah, this way I go on the surface now. हा करायचं दादा. हा करायचं दादा. Okay, sir. Okay, sir. Dr. Raj or Dr. Aarti, please proceed with the commentary. Instrument selection.
We have to have something which is a rounded burr. So to observe the tip of this burr is also rounded. Usually what the burr that we prefer is an F11. So 11 number burr is usually a 1 mm dimension. So we have a 1 mm margin so that the whole burr which can be utilized to create that margin. And then we do a biplane of abrasion. That is a smooth burr. It is not a finishing burr, it is a more of a gross cutting burr, and then the finishing can be done by a finishing paper burr. But that bird really gives you a very well rounded margin, and because in the anterior spindulators and gingival retraction take the margins a little more subgingival. But only thing is that I would suggest is whenever the alignment of the then we can reach the line, reach the practice the same way.
Akara.
And door width is 1 mm, so if you use the whole door width to create the depth loop, then you can have a proper amount of reduction even on the radial surface. Now, because this insider is already factored, you don't need to give any depth loop in the insider or inside that surface. But the remaining area, you can definitely use the bow and then
Akara.
rounded end of ball, not a flattening ball for this.
आकरा. तोंड उघड ठेवा. हा करा. तोंड उघडा दादा थोडस उघडा अजून उघडा. हा असंच. तोंड उघडा. मी तोंड बंद केलं दादा माझं काम नाही होणार. हा हा असंच उघडं ठेवा तुम्ही जेणेकरून मी काम करू शकतो.
So we usually SR level. So that is the straight feature with a rounded head. SX would be straight feature with a flat head. Instead of SS, it will be SR level. So you have SR11 and SR12. So 12 usually becomes a more wider work. We prefer to go more conservative, so that's why we use the SR11. Yes, you have to go in for a biochemical preparation and it would be giving us more better estimate.
So then the first place would be for the
Yeah, we can have an incisor stroke, right?
that's a beautiful view of the drop. So that's the other starting the drop, line is low, what is we have to emphasize plus
Yeah, so you have to have the same path of insertion and removal. Now, even though these are different crowns, are not joint crowns, we can have get away with a little bit path of insertion, but you could change. But then you will have to remember which crown goes insert first for the time of cementation. It should not happen one crown is cemented and then you're waiting for the other crown to, that there is no pathway for that other crown to go. So
Assets.
but yes, because we are not changing the alignment of the seat or something like that, because slight corrections can easily manage at the time of printing.
We have a little off-topic question, but it's pertaining to the material science because of the materials that we'll be using today. So in cases of attrition, generalized severe attrition, what would be the material of choice for crowns? Would it be zirconia or Emax? That was the question.
So I have a very uncanny answer to this. So if you want the tooth opposing to the crown that you're giving to break, you can give zirconia. And if you want that if the forces are too high and the crown breaks and the tooth survives, you can give Emax. So that's an uncanny answer. But coming back to, in a proper way, if it's a generalized attrition case, when you give zirconia and if the other teeth are not rehabilitated and they are wearing off faster because they've lost a lot of enamel, so what's going to happen is that the other teeth are going to wear off much faster than the zirconia that you have put. And over a period of time, you will end up with those crowns being a high point over there and leading to some or the other problems. On the contrary, if you give an Emax, it is more towards or has a more closer modulus of elasticity like a natural tooth. So it would wear and tear more close to a natural tooth than a zirconia, but it would obviously risk some amount of fracture over there. So it's a very difficult thing, but if given a choice, Emax would be my choice of material over there.
Thank you very much, sir.
See, a question has come in here asking us, you have not done post-endodontic restoration as a complete tooth and then doing the preparation. As I'm a conservative person, we have a very, very clear perception of the tooth length and morphology and dimensions. So usually prosthetic people will prefer, that's a clinician preference basically, nothing scientific about it. So my mind and my eyes can easily contemplate where a composite would sit here. So I usually would not need a composite to guide me for the preparation. I can assume its location, contemplate and work. So what we intend to do here is if a post-end core is required, we can do a post-end core, or a core buildup is required, I can do a core buildup, no problem. And we are viewing this preparation almost at 20x magnification. So as I described, anything that I do will be enhanced. So far, all of you must have seen the utmost precaution taken to induce no trauma, or the burr has not touched the adjacent teeth or induced any significant bleeding so far, except a point. तर ओके चाललंय ना? Are you okay? Any suggestions, please? No? Anywhere I'm going wrong? आकार आकार हालू नका दादा, थोडंसं खाली पाहायचं. हा बा झालं, इतकं इतकं. हा those enamel margins are sharp. We'll process them later after we are done with the preparation. Yeah, we have separate set of instruments, sir. GMTs we have and cutting burrs we have. Yeah. Yes, sir. Right now it is very basic, only 2 burrs. Hey, हालू नका दादा. फार बारकाईचं काम करतोय मी. तुम्हाला मला थांबवायचं असेल ना, तुम्ही आवाज फक्त वरती करा दादा. हा करा दादा. व्हेरी गुड, थँक्यू. ओपन. दादा थकलात का आपण? दादा थांबू का थोडा वेळ? करू शकतो काम आपण, काय नाही प्रॉब्लेम ना तुम्हाला? स्थिर राहा, आरामात बसा. तुम्हाला काही त्रास वगैरे असेल लगेच सांगा मला, मी थांबतो बरं का, आपल्याला ब्रेक घेता येईल, काही इश्यू नाही आहे. There is a gingival overgrowth, which is a challenge here. I can appreciate that in the microscope because of the fracture line gone down there. So I'll see how I can best manage it in the preparation. Water. Yeah, that is a gingival problem. So let's get away from it and do something about it. Something fell down. I hope not the ceiling. Okay, the rest is fine. This is the problem area. I'm saving myself from that corner. Here, creating a margin in this area. करा 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 दादा दादा तोंड उघडा तुम्ही बंद केलं ना की आपलं काम खराब होऊन जाईल बघा प्लीज तोंड उघडच ठेवा You see, I'm going subgingival palatally here and establishing a margin. चालू करा रे. I told you the gingival problem area. Oh, entangled. Thank you, madam. A lot of clutter of wires here. See, I told you the gingival problematic area of the crack line when we had a fractured splinter. We did not think of a periodontal correction here because it is negligible and I'm getting good margin in that defect, if you can see. So not subjecting the patient to an additional surgical intervention and to cut short the treatment time, I think we have a peripheral margin. Our circumferential tie appears to be a satisfactory one here. Okay, so gross preparation of this tooth also is over. I'll proceed to the fourth tooth now. Lock it. Hey, लॉक नहीं किया बेटे वर्टिकल में मूव कर गया क्या वर्टिकल लॉक किया करो जरा असं नाही तुम्ही आरामात राहा तुम्ही हलूच नका दादा line of draw, line of draw, line of draw and preparation. पाणी चालू करा रे. Where all do we have people live from? Which cities? Can I get a list? Kishore sir will brief everyone about it. We are happy to have a lot of gathering with us today. हाँ, त्रास आहे काय दादा? बोला बोला.
है दादा ना.
होतंय का? अच्छा, ठीक आहे. बेटर नाही, ठीक आहे. एल देऊन टाकतो. हा करायचं, हा करायचं, हा खाली बघायचं, खाली बघायचं. We are taking a break just for a minute. दादा तुम्हाला इंजेक्शन देऊन टाकतो बोलीचं.
Just for the information, I'm just informing few facts. We are live right now in 9 states,
म्हणून बोलीचा
and approximately 12 centers are there in which it is to be displayed on the screen is going on.
Understand why I
So I'll read the few names of the cities. Ahyanagar, Ahmedabad, Amarnagar, Akluj, Aligarh, Ambezogai, Amritsar, Aurangabad, Ayodhya, Badlapur, Begun, Howrah, Balotia, Bangalore, Barkheda, Baripada, Batinda, Bid, Behrampur, Bhagalpur, Bhopal, Bhubaneswar, Buldana, Bid, Chandrapur, Chennai, Sambhajinagar, Chiprun, Chittorgarh, Dehradun, Delhi, Dharamnagar, Diamond Harbour, Dibrugarh, Dombivli, Itwa, Faridabad, Ganganagar, Gaya, Gorakhpur, Guwahati, Gwalior, Hanuman Nagar,
in the needle.
हजेरीबाग, हिंगोली, हैदराबाद, इचलकरंजी, इंदौर, जयपुर,
हे काय आहे?
जमीनानगर, जम्मू, झांसी, जोधपुर, कलबुर्गी,
हे काय?
कल्याण,
हे काय?
कानपुर, कौसा, खारघर, कोल्हापुर, कोलकाता, कुचमन सिटी, लातूर, लखनऊ, लुधियाना, मदुरई, मैंगलोर, मंचर, मिंदापुर, मुंबई, नागपुर, नासिक, नवी मुंबई, न्यू दिल्ली, लखीमपुर, पनवेल, पटना, पुणे, रायगढ़, हुमला, रामपुर घाट, रांची, रोहतक, सिलेट, शमशापुर, संगमनेर, सटाणा, सातारा, शिरवली, शिंगोली, शिरोली, सोलापुर, सूरत, ठाणे, उदयपुर, Vasai, Yamunanagar. So these are all states we are going live currently, out of which I told you 12 centers, they are directly screening on the big screen into the big hospitals or in the dental colleges where numerous people are watching it all together. Almost 600 people are watching it on the screen in various institutes and the hospitals. Another, it is also watched by many of the private practitioners into their clinics. So this will be really helpful for the private practitioner in basically in the decision making that you take if such a case arises, because we have variety of opinions, there are some views, contradictory views, but what we have try to answer almost all the queries in relation to treatment plan about this case. And I hopefully feel that most of the people who had doubt about the treatment planning, they must have been cleared. So if they face similar case or a case like this or any situation like this in their clinics or in their practice, this session will really helpful for them to take a decision about the final treatment planning and how to proceed with the preparations. So we are almost about to done with the preparation. After that, the lab procedures will be followed. So I'll join you soon after a few minutes. Thank you.
Thank you very much, sir.
Sorry. Tissue. बरं आहे ना दादा, दुखत नाही तुम्हाला, काही त्रास नाही ना? तुम्ही म्हटलं तर ब्रेक देऊ तुम्हाला, दादा. तुम्हाला सांगा ब्रेक पाहिजे म्हणून. हा, सलग काम करतोय ना मी 4 दातांचं एकत्र. माझं संपलं की हे करतील ना डॉक्टर आरती किंवा डॉक्टर राज सुद्धा तुमचं काम करतील आता. राजेंद्रला बोलवा. माझा फोन बघ बेटा, माझा फोन बघ कुठे आहे. माझ्या खिशात आहे तुझ्या? ओपन. हा, असंच तोंड उघडच ठेवा. हा, आपल्याला काम करायचंय ना. Hey, don't take the screen. Remove the suction. Cut the suction sound. फोटोग्राफर कुठे गेले? सर आलेत. We have had the pleasure of having Unmesh Khanvilkar sir, Professor, Department of Microdentistry, MUHS. I request Dr. Kishore Sapkale sir to felicitate Unmesh sir here. Mayank sir, please. Resham ma'am, please.
Thank you, sir.
सर धन्यवाद. अमृत भावी. एक मिनट रुक. We also have Amrut sir here. Amrut Bambawale sir, please come sir. I request Aji Saligram sir to felicitate Dr. Amrut here. Aarti ma'am has come in. You glove.
Yeah.
Manoj sir, please. Thank you so much for coming in, sir. So now we have established circumferential tie or the margins for all our teeth of 1 to 1 2 and done the mesial, distal, facial and palatal reduction. I request Dr. Raj Salvi here to do the final finish to the preparation. Then I'll take care of the margins mostly if required. Over to Dr. Raj. बरं वाटतं तुम्हाला? ठीक आहे ना? आरामात बसा. छान होईल. सर थैंक यू. यू आर हैप्पी, आई एम हैप्पी. बट हैप सर हम लोग खाने का बोल रहे नहीं नहीं ऐसा थोड़ी चलेगा. ये जबरदस्ती है. भारत भारत let me tell you the further course of action here. After completion of finishing of the preparation, we are going to obtain a scan, post-preparation scan, from which we will obtain the optical impression, articulate it in the software, and design the restoration in ExoCAD. We are going to design restoration in two different manners. One is to temporize it with PMA, polymethyl acrylate, and one is to do it with zirconia. Zirconia and polymethyl acrylate, both we will mill in the milling machine. Acquisition will happen through an intraoral scanner. That image will be exported to the same laptop that you saw in the morning. There we will use ExoCAD software to plan and design these restorations. Again, to match it on the similarly that you saw in the morning, same will be repeated. After that, we will again use the same to design a temporary. Temporary will be a PMA disc. May I have the disc, please? Zirconia disc as well as the PMA disc. होशियार सिंह जी वो डिस्क दीजिए जरा, माइक रखिए. Yeah, this is PMA. If you can focus the camera on this. See, these are 4 temporary crowns cemented. This cementation, milled. This has been milled as per our pre-operative smile design. So they are almost similar to what preparation was contemplated on the soft copy. So what point I'm trying to make here is digital dentistry allows you to anticipate a preparation, contemplate and plan it, digitally execute it, and mill a prospective emergency, or what you call it as emergency crown or urgent crown. So you anticipate a preparation digitally, you prepare the two digitally, make a model, mill the crowns, keep them ready, and immediately cement it. That again is a gateway opened by digital scan. This is the disc for zirconia. This will go into the milling machine. This is the milling machine. I will demonstrate the machine later. This is the machine, milling machine we'll be using today. I will describe the parts of the machine and the way the machine works. This is a 5-axis milling. This is a dry milling machine. And in the corner that we have is the sintering machine. So after the zirconia is milled here, it will be sintered in that machine. Okay, and beyond that, for demonstrating it to the students, undergraduates and postgraduates and private practitioners, we have already prepared a mock-up 3D print of the arch. Yeah. There are 2 techniques which we anticipated, whichever we find correct. So what we have done is, this is the upper cast. Camera, can you come close to the model here? Yes. Is it focused? Yes. Am I audible clearly? Am I audible? This is on? Yeah, this is on. So this is the upper arch. What we have designed, what I showed you in the morning in the presentation. That design we have 3D printed and we have prepared a splint in the BioStar machine. Now what I can do, after the tooth preparation is over, I can make a hole here, an opening, an aperture for injectable composite to be inserted in this, and a small vent on the parallel aspect for the excess to come out. And after preparation, through the vent, I inject composite inside. I first surface treat the dentine, etch the enamel if it exists, apply the bonding, cure it. After curing, I place this. आपला कास्ट दे ना मला, अपर कास्ट दे, अपर कास्ट दे बेटा, नहीं pre-op कास्ट, pre-op upper कास्ट. हाँ. See, this is a broken tooth. Suppose if it is prepared, after this I'll obtain a model where it is prepared. I place this. Suppose this is a patient's mouth after preparation. I will place this with a small hole inside on the facial surface and a small vent in the backward area. Okay, a small hole, much lesser in diameter. And then put injectable composite here if I want to bond or don't bond, and then develop that much part. If I have to prepare it, a composite build-up before starting the preparation. Do you understand? And then now what we will do is index and the upper model. Upper model is with me here. Yeah, it's sit with me here. This is the model that we have from which we have obtained a rubber base impression, and this is acting as a putty index. And we'll put our temporary material here, temporary crown making material, and then use this putty inside the patient mouth to make the temporaries. Simultaneously, from the scan obtained, we will show you how to mill the temporary crowns from the soft copy of the impression into the milling machine. Today's time duration we have slightly prolonged, so we are going towards the fag end of the day, so we may not be able to complete the sintering process. When we started working on CAD cams and using AI on the making of restorations in 2011, back then we used to have sintering time of 16 hours, which was later cut down to 8 hours. The current machine that we are working on today has a sintering time of 3.5 hours. So after obtaining the scan, designing of the restoration in the ExoCAD, milling it here, milling would not take much of time. Approximately each crown unit will take around 6 minutes, 8 minutes max to get milled in the all ceramic. However, it will not be sintered. So sintering will happen in that furnace, will take around 3.5 hours time. So to show you how it will work, we will mill one in the available shade. We have A2 shade available today. No, A3 shade, I guess. Not zirconia, PMA. PMA, we have A3 shade, which is not a great match. And zirconia, we do have the matching shade naturally. And in the temporary material, we have A1 shade. So that is going to match. Our zirconia is going to match. Our temporary acrylic will not match. So what we have demonstrated overall is tooth preparation, margin preparation. We have deliberated a lot around where we require a post and core, where we require a composite build-up, where we do not require a composite build-up. And hence, all four of them turned out to be not needing additional composite build-ups and additional any post and core reinforcements. So no coronal radical stabilization was needed. No extensive periodontal surgeries turned out to be needed. So fine, we have gone through all the preparations. We are obtaining the scan. Followed by the scan, we will now go to the ExoCAD for designing of zirconia crowns, permanent crowns, temporary crowns, and intraoral technique for fabrication of temporaries. If not doing single visit. Though we are single visit, we will demonstrate you the technique for temporization, which will hardly take around 15 minutes time. Thank you so much. Back to Raj sir. You're completed? You've completed all clearances, all fine, good, nice, nice. No sharp things, nothing. Just we'll go on a higher magnification to see if we need any finishing.
It's slightly.
Yeah, no sharp points. Yeah, can we have a GMT here? I'll just ensure that I make the margins. I'll remove the unsupported enamel. Acha, diopter setting at 1, I don't need my specs. 1 minute, huh? Sir, you will directly first scan it and then use the temp, okay? To make the temporaries. Thank you, Raj sir. Great help and guidance. GMT का है? हाँ. Boom. We have done it nicely. Almost everywhere, sir has already ensured that the margins are reasonable. So this I need to. Can you actually see I'm scraping off the unsupported enamel? Can you see that? See, I broke it. So this area, these are the unsupported enamel area without inducing bleeding. You see the debris coming out? I wipe them off. The crystal of enamel will come out. This is how you use a GMT, okay? Everybody has studied it in the UG life. Nobody practically uses it. It's an amazing device. See this. None of your zirconia or your luting can ever match it. See, I'm breaking it. Yes, I broke it again. Mind it well, the direction. Okay, I'm only using the distal ones. Aha. Now I use the other end, other GMT. This instrument is not great. It is not sharpened only. See how the manufacturer has supplied and the purchaser has purchased. There is no sharpening edge only. There's no cutting edge to this instrument. It looks like a GMT. Imagine a blade not having a blade. It's a reputed company, for God's sake. Can't work, can't cut. You can't use a wrong direction. I will use it like yes. You see that? And you can hear the sound of breaking enamel. Yes. Fine. Let's start with the scanning. Hand me the scanner, please. Chalo. Hand me the Yeah, form fill kar diya? Can you connect the screen directly again, Bala? Screen directly क्या? अच्छा connect किया ना, very good. This screen is connected, no? Yeah. नाही आपोआप स्टॉप होईल ना ते. पकडा ह्याला मजबूतीने पकड, पाडू नकोस बेटा. स्कॅनर यू टेक केअर ऑफ. हा, गरज आहे का त्याची? मला नाही दिसत रे. नाही इतका उजिंग नाही आहे. मी तर जिंजावर इन्स्टॉल अजिबात नाही केली, सरांनी पण नाही केली जास्त. वी डोंट हॅव मच ऑफ उजिंग हिअर. छान आहे. उलट कसं आहे, इफ यू यूज अ वॅझो कन्स्ट्रिक्टर स्पेशली एड्रेनालिन बेस्ड, it gives you immediate vasoconstriction followed by sustained peripheral vasodilatation. So if that happens, you have more of oozing later. So all vasoconstrictors or any moisture control measures should be used very judiciously by understanding the mechanism by which they work. Yeah, nice preparations, I guess. Yeah, it's all good. Raj sir, labial support to the left lateral. Just have a look once. Is this too much or alignment में ठीक हो जाएगा?
You can reduce it a bit on the inside.
नजर हटी दुर्घटना घटी.
Inside the curve.
Yeah, that's what I saw just now. This way, no? थोड़ा मॉडिफाई फिनिशिंग बर से हल्का सा कर लेता हूँ. ऐसा? This way? So? Fine. Sharp edge. ठीक है. See the scan and then see it. Chalo. We'll see the preparation in the scan. If need be, we will modify the preparations or add vertical height also, axial height. Shall I start? Upper arch. I keep it pressed. Single click पे ये. Okay. There's no music to the. Open. हाँ करो. हमारा फूड कंट्रोल पे चलता है, हमको उसकी आदत है. डन. यस. हाँ कर. हमारा लाइट बंद करूँ क्या? माइक्रोस्कोप का लाइट. ये माइक्रोस्कोप का लाइट बंद करो बेटा ऊपर से. जस्ट स्लाइड बंद करो और कुछ नहीं करना। वेरी गुड, डांस करो। जैनब, जैनब किधर है? हाँ करो। We started scanning with blue cam in once upon a time. काय झालं रे ह्याला? Earlier, it used to take multiple images, two-dimensional pictures on which all the scanners used to work. I've worked on blue cam for a lot of years, where it used to capture multiple images, stack them together to convert 2D photographs into a 3D image, then virtually unite all entire thing to make a model. Nowadays, these devices use videos. They create a matrix, something like a snippet. It uses triangulation technology. Moreover, I think we are, except this smaller area, we are done. होशियार सिंह जी, ठीक है हम लोग? सिर्फ बक्कल ऊपर का ये एरिया थोड़ा डेफिशिएंट आ रहा है। हाँ, आर वी ओके? फिंगर क्लिक, चलो स्टोर कर दो उसको। We have, the software is processing the image. Zainab madam is here. Good. Yeah, we'll take in mandibular now. डिट्रैक्टर डाल देता हूँ लोअर के लिए, नहीं तो हाथ से ही कर लेंगे। चलो ठीक है, स्लाइटली क्लोज करेंगे सर। हाँ करो।
एक तो मेंटली
हम्म,
एक तो डाटा लगा
हाँ करो। थोडंसं थोडं दादा वरती बघा, हां खाली वाकू नका। डिट्रॅक्टर टाकायला लागेल, पकड रे इसको। हा करो, हा कर, हा करा। बंद करा आता, हां द्या मला। अरे रे प्रोसेस कर गया हूँ, कॅन्सल करो, बंद करा, बंद करा, बंद करा, तोंड बंद करा दादा। हां सॉफ्टवेयर इज गुड। हाँ होशियार सिंह जी, सॉफ्टवेयर अच्छा है। आकर 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 बाइट पे आ जाएगा। हाँ आकर करून ठेवा. थोडं बंद करा, आंशिक बंद करा, पूर्ण बंद नका करू. बस बस एवढंच बंद करा. आर वी गुड? Now the software is processing the lower impression. ठीक है. So the software has auto-deleted the excess tissues around the tongue which had come. And otherwise, normally in the older softwares, we have to manually remove it, trim the digital impression. But here, this is an auto thing. That's very good. Now I'll register the byte. Please select the byte. हां, साऊंड ठेवा गच्च, दाडांवर दाट साऊंड ठेवा मागचे. हां, okay. Acha, you want me to select first? Okay, what you selected? Fourth quadrant. Okay. Single click. Huh? Done. Good. Close. बंद करा, साऊंड ठेवा. Other quadrant ना? अच्छा, right side bite it is registering. Good, good. Because either bilateral symmetry is not there in the occlusion. So good we have separate. बरं वाटतंय ना? ठीक आहे ना तुम्हाला? त्रास होतोय काही? दुखतोय तो? अरे हां, सॉरी सॉरी. 2 मिनिटात संपेल. त्या रिट्रॅक्टर लावाय तो. साऊंड ठेवा गच्च. हां. कंप्रेसर बंद करा रे. झालं पण छान. एंटीरियर बाईट घेतच नाही का? It will get properly. Nice. So that's how we have completed taking the optical impression, or what you call as a clinical scan. Now get on to the software for designing. We will make the model, virtual model and articulation. To connect the laptop in that corner only, better. अच्छा, तो आप वहां से काम करेंगे, हम लोग यहाँ से बात करेंगे, चलेगा जी? तो आप ये लैपटॉप को उधर ले लेंगे जी. हाँ, प्रोसेस होने दीजिए. आप रोक दीजिए. किल साऊंड, साऊंड साऊंड किल केलंय सगळ्यांचं. We have completed the tooth preparation. After tooth preparation, we have completed intraoral scan, upper and lower scan, and we took the bite, scan of the bite. We have articulated the model. You can see on the screen, the work is in progress to see how the preparations have come out. Now, followed by this, we will now go to the ExoCAD and design the restoration. And we will mill the PMA crowns, and we will design permanent restoration and mill it for zirconia. And by the time we are milling it and sintering it, we have Dr. Resham Pakmode with us, who's a renowned periodontist working in GT Hospital in Mumbai, Gokuldat Tejpal Rugnalaya, Mumbai. And she's going to demonstrate us suturing techniques. So that's how both the things will go on simultaneously, because when it goes for sintering, it's going to take good amount of time. Okay. Over to the chair. Dr. Aarti has modified a small undercut which was seen in the lateral incisor. So after we have removed that undercut, now madam is scanning the arch again. As all of us have seen that the mandibular canine in question, which I showed you in the presentation, is having a very elongated tip, a very, very elongated tip. Normally, when the canines come out and establish an occlusion, usually it's a canine guided occlusion. It's a canine guided occlusion. So there is a wear. So wear happens continuously throughout the life of the individual. So when the teeth come out, they have a very sharp cusp tips which blunt off. And ultimately, when the entire canine is grounded off by adhesion, the whole mouth goes into a groove function. In this case, canine being placed in a retrocline position, it never underwent any adhesion. So the canine tip is very sharp and very long. That is very deleterious or harmful for any restoration that we place in future. And that long a tip of the canine is not useful by any viewpoint of any function. So what we are going to do here is blunt off the tip of the canine a little bit and then proceed with further procedure. So Aarti madam is here to blunt off the tip of the canine. Over to the chair. We are through the acquisition phase. Now we go to the designing phase on the ExoCAD. So let's connect the screen on the ExoCAD here. We can pick the laptop up and come onto the desk. Yeah. After the processing of the scan is complete. The software, how it works is when you scan a surface, after when you scan it, it throws light on the surface. Light gets reflected back to it. It creates multiple points onto the surface topography of whatever is being impressioned or whatever being scanned, and each dot that it digitally designs or assumes is calibrated into coordinates x, y, and z axis in coordination with each other. That's why morphologically accurate impressions can be made. So it triangulates each dot in comparison to the other dot. That's how it actually creates a virtual web of the dots together and creates a 3D impression. So now we have completed acquisition. The software has processed the information. We are proceeding towards Exogas software for designing. Come. हाँ, आरती मैम को हैंड माइक प्लीज. हाँ, I am going on Dr. Resham's desk. So you, Arti ma'am, design the restoration along with him. Now we are pulling that optical scan into the Exocad software first. Yes.
We are starting the pinpointing for the margins everywhere now. Locating all the margins everywhere.
Auto detect function also is used in this.
But if we have
If you have
die-cut model,
die-cut models, huh?
okay.
The other software that we use has the facility for identification on its own. Here you require a die cutting. In this software requires die cut model to do it. To height.
If you observe the margins, everywhere the margins are of the equal dimensions. Because this is a zirconia crowns, we require the margin width as the same, both labially as well as on the palatal aspect.
Path of insertion.
So this is the path of insertion of the milling that has been decided.
Presentation.
The cementation would be the same but it will be an individual cementations. Tapered one.
In this one.
Yes, that's one. You have to select amongst the library which one, which is the taper, which is the shape of the teeth. You have ovoid, square, tapered. So if to select amongst the library that is there, we can arrange the teeth according to our margins.
Showing the pre-op cast. Pre-op cast. Pre-op cast. Upper model. I need maxillary model. Actually, both. Pre-operative. Yes, sir. See this. अभी हम लोग कैसा मैन्युअली ड्रैग करते हैं इसको, इसमें क्या फंक्शन है सॉफ्टवेयर में देखिए.
ये मूवमेंट्स है.
ना ये जो आया है ना, ये एंगल मुझे ये टेपरिंग चाहिए सर्विक्स टूथ का. माउथ में वैसा है ना,
तो वो आपको कटिंग दिख रही.
ना आपका डिजाइन ही देखना है. फेशियल व्यू से टर्न करिए. हाँ, डाउन लेबल व्यू दिखाइए. यस हाँ, ये ना, और थोड़ा नैरो कर दीजिए इसको.
ये वो किस सेकंड स्टेज में होगा, अभी करना है तो अभी
नहीं, बाद में कर दीजिए, नो प्रॉब्लम.
ओनली प्लेसमेंट स्टेज.
अच्छा, this is a placement stage. Okay, this software works differently than routinely used by us.
कर सकते हैं, लेटेस्ट सॉफ्टवेयर में ऑप्शंस है.
Okay, the option, हाँ. ना, you do it आराम से. मतलब right now you're only placing it, angulations. Okay, fine.
We'll have to take the incisal edge. ये जो edge है नीचे का, उसको थोड़ा नीचे लेना पड़ेगा हमें.
This one?
Yes.
हाँ. ये वाला जो दांत है, राइट साइड वाला सेंट्रल साइड, थोड़ा ज्यादा ब्रॉड हो गया है.
ओके.
हाँ, मिड लाइन आपका थोड़ा सा
नहीं, इसको मेजर करो दोनों का विड्थ मेजर करके बता दो आप. See, what we are doing is measuring the width. There are tools available in the software, as you can see on the screen. So keep it both same. I have asked him to take a template. So I and Mr. Hoshiar are working together here, along with under the guidance of the prosthetic people, Aarti ma'am. 8.29 mm is the vertical height selected for the left central incisor. Right, if you see the gingival zenith slightly superior, so we will compensate in the design.
8.27 approximate.
Okay, fine. And we want the narrowing here, slight more narrowing here, so that teeth are having a triangular form. If you classically see the basic classification of tooth forms. Teeth are ovoid, squarish, and triangular. We broadly categorize them into. And this patient's morphology, natural morphology, falls into the category of triangular teeth. So slight cervical tapering would look more natural in this case. It will blend more with the original aesthetics of the patient. Yeah, we are dragging it more correctly towards the margin. थोड़ा और जाना पड़ेगा. Yes.
ये सर में
ये
रिड्यूस करना पड़ेगा आपको approximately.
थोड़ा सा ना प्रॉक्सिमली थोड़ा सा इस साइड लेना पड़ेगा आपको.
फर्स्ट सेकंड प्रॉब्लम.
सेकंड कॉर्नर.
measure the width. नहीं, height of contour पे measure the width here and here. Yes, so that we have bilateral symmetry in the width. Sir, see.
मर्जिंग के बाद ही वापस नहीं, अभी हम प्लेसमेंट में अभी भी मर्जिंग के बाद.
नहीं, ठीक है, चलो आगे चलो. Don't let's not waste time in this. Yeah, this is the line of draw or placement.
You want to some ginger? You want to
Okay, so gingival porcelain can be added anywhere if you want to have the modification in case of some margin where some tooth are specifically very high up and you want to add gingival porcelain and all that can be modified out here.
The software has data of thousands and lakhs of teeth inside. So after looking at the preparation and the placement that we have designed, it will take a design automatically on its own. So whatever you call algorithms or AI or whatever you call it as, so it will give you a strong suggestion. If you accept the suggestion and send it directly for CAM, it will start manufacturing. So we are to customize it as per the clinical experience, because the software is only aware of the impression and the adjacent teeth. It gathers the data from the premolars and the canines here and the opposing antagonizing incisors to contemplate how can a form for this 1:1:2 can be. But the software has not seen the patient and the preoperative photograph. So it has to be a combination of the algorithms of the software suggestion and your own clinical judgment.
Contact be coming with the lower one.
Yes, see, this canine is the culprit as we had discussed. So what we are doing, we are using a tool to reduce the ceramic. As you use in the paintbrush to add some material, sprinkle or remove and erase with an eraser. Similarly, we are looking at the contacts here. Yeah, arch form has to be maintained. I think slight marginal gap here, central incisor, cervically, height of contour.
सर शोल्डर है, और आप और चीजें हम करेक्शन कर सकते.
Don't. शोल्डर तो वहां पे इक्वी जिंजाइवल है, सब जिंजाइवल है. क्लिनिकली चेक कर रहे हैं पेशेंट पे. पेशेंट इज गॉन ओके फॉर अ ब्रेक. ना.
अगर आपको अब हम इंक्रीज कर सकते हैं इसको, अगर आप इंक्रीज.
Now let's confirm it, because I remember making it equigingival, which they finished to subgingival mostly. So it cannot be supragingival. So the crown will come short.
ये देखिए मार्जिन इसमें आपकी जो दिखती है वो पूरा
Subgingival है.
gingival जा रहा है.
Anterior aesthetic young male patient है यार. We will not get it supragingival. No. The margins are not clear on the scan. In the mouth, they are very clear. You want to repeat the scan? Then I see it here. Aarti ma'am, there's no.
Buccally, buccal view दिखाओ.
है ना, यहाँ से बकली में थोड़ा आ रहा है.
तो हम मार्जिन शॉट हम उसको चेंज कर सकते हैं.
हाँ तो
Change the margin.
किस पे करना है?
नहीं नहीं, आपने मार्जिन बराबर लिया है। आपका जो बिल्डअप आ रहा है, बिल्डअप में शॉर्ट आ रहा है।
यस मैम, वो शोल्डर है। बाद में जब मिलिंग होगा तो परफेक्ट वो जगह पे आ जाता है, क्योंकि जर्कनी ऑलमोस्ट एक्सपांड हो गया था इसकी।
ठीक है, समझ गया।
अगर आप चाहते तो बॉर्डर और मैं एक सेकंड आपका जो क्वेरी है उसको सॉल्व कर दूं।
We are, for so many years, we are using the same software. So we are used to different work. So we normally take around 3 minutes for the entire designing. So I think you must be also taking the same time, but as we are interpreting your work, इसमें बराबर आ जाएगा. चलो ठीक. It's a different design of the work.
Fine. This is how it's going to look at the final one.
Yeah.
There is a slight marginal discrepancy which is coming in this.
With it,
Yes.
just merging it.
Okay. Actually, the gingival zenith of those, both the teeth is at a different level.
One is slightly broader.
Yes.
Proximally. Cervically.
That's what I'm changing. When change the design.
Just make it little vertical, not the one.
नहीं, आप इसको वाइड करोगे ना तो ये और बल्कि दिखेगा।
मैम वो आफ्टर फिनिशिंग आएगा।
अच्छा।
अभी हम उसको फिनिश भी कर सकते हैं या तो सिरामिक को फिनिश करो उसको जैसा आपको चाहिए।
Okay.
अगर मैं अभी कम करूंगा बाद में ऐड नहीं कर सकते।
बाद में ऐड नहीं।
हम थोड़ा सा एक्स्ट्रा देते हैं हमेशा, तो आप फिनिशिंग में निकाल सकते हैं।
ओके।
आप बोले कैसे बढ़ाएंगे?
हाँ, make it horizontal. Just reduce this part slightly inwards.
Wait. Okay.
Add slightly here.
Yeah.
No, not there. One more.
This one.
Yes.
One more.
Okay. Yeah.
No. This needs to go down, and this one.
क्या आपको ये इंक्रीज करना है आपको?
ये मुझे ऐसे
एक मिनट नेक्स्ट स्टेज में होगा।
ओके,
बट वो बात 2-1 नेक्स्ट।
अब देख मर्ज नहीं हुआ है,
नहीं हुआ है।
मर्जिंग के बाद हो जाएगा। आपको जो देख रहा है इससे ज्यादा आएगा हाथ में। बाद में क्योंकि हम 3D में देख रहे हैं ना, तो हाथ में तो एक्चुअली कुछ और ही आने वाला है। तो आप जितना करेक्शन करोगे वो एक्स्ट्रा होके आएगा।
ओके।
जर्कोनी आएगा, ये जर्कोनी एक्सपांड होता है ना।
Can we make it like a mirror image of each other, 1 and 2?
Yes, why not?
Let's try that.
don't do it. The reason of this.
ये फिनिशिंग में से निकल जाएगा।
ओके।
चलो फाइनल कर दो इसको जल्दी से।
फाइनल तो हो गया।
हो गया ना डिजाइन? ओके, डन। अभी PMA विल डिजाइन और विल टेक दिस अप फॉर मिलिंग डायरेक्टली अंडर PMA।
इसको पीएमए मिलिंग कर सकते हैं।
ये तो कांटेक्ट हटा दो। स्ट्रेस
यस यस से माइंड
तोड़ेगा वो।
वो भी
It will break the restoration.
अब भी कर दो।
See what you see on the screen. Yes. Good. We are keeping it out of contact. Keeping it out of contact, not completely. We are not giving occlusion there at all, as there is very high level of forces we are getting there. I'm used to the other
नहीं, on
software.
central we will have to have a contact.
There are no contacts on centering service.
They require contacts, centric contacts.
Guidance is steep, no?
वो आ जाएगा.
आ जाएगा ना? Protrusive आ जाएगा. So let's prepare for it. हा पेशंट आहे ना कोणाला दाखवतो वर्किंग कोण आहे आता This is Apsara machine. This is the 5-axis milling. इसको ओपन कर दीजिए भाई. Okay. I've opened the lid. This is dry milling machine without a coolant. 5-axis mill, and this part is going to move. Normally in axis or 5-axis, 4-axis, 3-axis milling, the tools move in different directions. Here, there is a platform and there is a holder here of the disc, and that itself moves, and a single direction milling will happen. It apparently appears to be a single axis milling. All the 5 axes are included in the platform. So normally in other type of machines, your block or your disc is stable and the tools move. In this machine, they have designed it the reverse way. The block moves and the tool is designed the same way. And if you can focus closely onto this, different types of burrs required for anatomic details will be picked up by the machine on its own. It will detect, it will make a choice and pick up a burr from here and put it into the, can you show this? Yeah. This is the holder of the bar and this is going to work. So after we have completed the CAD portion, he will make a command for milling. So that will go into CAM, Computer Assisted Manufacturing. So now we go onto the screen, and by the time this is being milled, Dr. Resham will start demonstration for suturing techniques. So over to the screen of the computer, how the commands is given to start the milling process. And can somebody please load the block for the PMA? My audio is on? Yeah, it's on. Done. PMA shade that is available to us today is not matching very well. We may demonstrate PMA milling later. We will directly start milling zirconia disc. Okay, can you place the command zirconia disc only? Start the work. The machine will give you a live update of every single tool being picked up, time duration totally required, time elapsed, and progress. It will show you what level of axis angulation is being used with respect to all these parameters. X-axis, Y-axis, Z-axis, and the thickness is being used. All meticulous details are displayed here, and it will alarm you in case anything goes wrong. Load the disk. Yes, we are giving the command from there. Don't change the settings of the audio visual. Just you focus the camera on the main screen so that we don't lose time. So we are giving a command here for milling. Disk size 98 by 12. Giving it paths to receive the signals from the designed file selected and connected. Orientation, how we would want it to be on the disk. Can I show the milled one? Yes, this is the one. This is the one how we have designed the temporaries. Here is selecting in the central portion of the disk. The attachment stubs, they are need to be cut before removing it and trying out. Blocks that we have, they're all blue in color. And once the centering happens, they turn into the appropriate shape, which is described on the surface of it. But today, the disc that we have is a natural color of the same zirconia that we have. Chalo, complete the work. Zirconium you selected. Apsara blocks, crown, 5-axis milling is accepted. That the placement appears to be fine to me here. Closer. Single stub is safer. Good. We have arranged for horizontal location of where we want the crowns to be milled from the blank or the disc that we have, ceramic disc we have. Now this you can see the height is being adjusted because once you virtually see the placement circumferentially, perimeter wise, you have to again adjust the disc height wise. If that adjustment goes wrong, you will end up milling it partially. So now if you see the horizontal viewpoint also, it is adjusted well. So we have given the command to the machine to start the work. We are loading the blank. We're loading the ceramic disc here, A2 shade, Apsara block, zirconia. We have loaded it. Now we're placing it to lock it in place. It will show the status of your fit, right? Okay. Start milling. Start milling. Calibration is not complete. Okay, our machine does it immediately. Oh, fine. Oh, fine. So what the machine is doing, the calculations are going on for it to work with the tools in 5-axis. So you can focus it here. Yeah, it's almost finished. Calculation started. Section is complete. This is open system. That's why these steps have to be integrated together. If you have an integrated system, there is a continuous flow. Here, one part has to be calibrated with the other part for it to be imported. The scan had to be imported into ExoCAD. ExoCAD has now to be read and perceived by the machine. So if one software is regulating all three of them together, that's an advantage. Almost complete. 100% complete, yes. This is an engineering marvel. The machines that we have for CAD-CAM making and chiseling of CAD-CAM restoration, you'll enjoy seeing them if you haven't seen them. Normally, we would have a chamber down here for coolant, and there will be jets of coolant showered onto the cutting area continuously from all angles. Whatever axis cutting happening, continuous cooling will happen. And after the preparation is complete, after the restoration is complete, all the coolant will be sucked back again through a filter into the tank. And the debris will lie there for us to clean. That's how normally it mills. But this is absolutely dry milling, so there won't be a problem. There is no coolant in this. Sir, we are inserting the information. The USB will be read by the software of the machine. As I told you about the open system. Otherwise, what will happen if it is connected, integrated software, single software is designing and milling, there won't be a need of transfer of information. Bluetooth device, Bluetooth is connected to this, it gives command, it starts immediately. Now I'm going to start is it readable or reflecting? Is the plastic reflecting or the digits are and this thing? See, these are the axes of rotation. I'm starting it now. Focus on this inside part. See, the robotic arm on the top has come in and selected a tool. Can you show it? Is the camera focusing on that tool? Okay, good, nice. If you want to get the camera close, if you want to, if it is can be better. Finally, you have to go there. You see the tool, come in, come in. How's the definition? Good. ये इससे ज्यादा बेटर रहेगा अगर आप नजदीक जाएंगे तो हाँ तो आप नजदीक जाइए ना बहुत बहुत बारीकी वाला काम है संभाल के जाना आप वायर से नीचे गिरेंगे तकलीफ होगी नजदीक जाएंगे तो खराब होगा किस चीज का रिफ्लेक्शन आ रहा है
care is getting reflected on that lab.
Come, get it. Height नीचे ले लो. You see that it is milling out a crown. How much is the time? Milling time? Have a look at the milling time. It's 2% complete. This works on the compressor. How much is the milling time? 35 minutes. So milling time for all these 4 crowns is 35 minutes. So now we move over to Dr. Resham Pakmode for a live demonstration of preclinical demonstration of suturing techniques. So over to you, madam.
Thank you, sir. Am I audible? Okay. Thank you so much, Abrar sir, for handing over the mic to me. Good afternoon, everyone. I am Dr. Resham Pakmode. I am Assistant Professor at GT Hospital, GMC Mumbai. Today, I'll be demonstrating a few suturing techniques. Now, before we begin the whole procedure, I would like to begin with the armamentarium that we are going to use today. Now, since we want a very clear field of vision, we are going to demonstrate it on a model rather than a patient. First of all, let's begin with the incision cutting. As you can see on your screen, the incision is already being made, but I will run my hand through it again. So this will be the wound incision. If it is already an open wound, then let's not talk about it. But if we are trying to create an incision or we are trying to raise a flap, for example, in implant procedures or alveoloplasty or flap surgical procedures in periodontics, then we are going to give an incision. So this is how we are cutting into it. For your reference, I've already labeled this as the buccal side and this will be the distal most. So this, we will be starting our suturing with the distal most tooth and going mesial. That is how we generally do it. So beginning with the armamentarium that I'm going to use, I'll be using a surgical blade and a BP handle. As we can see, I've already made the incision. Okay. Then we have the suture material. Then we have the needle holder with us. And we have a surgical scissor to cut the suture material. And we have a tissue forceps. Now, there are certain principles that we need to remember before we start suturing. Now, what is it? After our surgical procedure is done, we need to ensure that each and every step that we do once the patient comes to us, irrespective of whether it's a surgical procedure or whether he comes with a laceration or a wound, we need to remember that the area that we are focusing on, it has to be absolutely sterilized or cleared. For example, let's give an example. Since I'm a periodontist, I will be focusing more on the periodontal flap surgery. Now, when it comes to periodontal flap surgery, I would like to draw your focus on this field of vision over here. Now, for example, this is the buccal side, buccal surface of the alveolar ridge, and this is the lingual or the palatal side. This is the distal, and this is the medial. So, for example, let's say we have raised the flap already, and we have a gaping suture, gaping wound that is present. Now, first of all, after our entire incision and reflection is made, we will be clearing that area and we'll be completely, treating the inflammatory tissue that is present. And after the whole entire clearance of that area is achieved, we will be then going on to the suturing procedure. Now, there are certain basic things, irrespective of whatever techniques you're using, whatever flap surgeries or whatever procedures you are performing, there are certain principles that we need to remember. One is, as I said, that we need to ensure that there is no underlying trapped edema that is present or the inflammation that is present. We need to remove it. If possible, we can remove it with a hand pressure, with a thumb pressure, light thumb pressure. We will already be clearing the inflammation with the help of our curettes and with the help of our, surgical scissors as well, trimming the excessive flap. After we are done with that, we will be making sure that the tissue is a little healthier. There will obviously be a lot of bleeding. So we will be clearing the bleeding so that we have a clear sight of vision to ensure that we are correctly placing our suture needle and the suture material. Second thing is that we need to focus on what kind of material we are using for suturing. Now we have, there are three components, as we can see on this. There are three components in the suturing material. One is the needle, and the other will be the actual suture material, okay, as we can see over here. So there are different kind of suture materials that are present. For example, we have the silk sutures, we have the vicryls. So we can basically divide them as resorbable and non-resorbable. We can divide them into synthetic, natural, etc., coated, non-coated. So let's focus on the one that we have taken today, and it is the 30 silk. This is generally used in a lot of periodontal surgeries. This is a non-resorbable suture. I generally personally try to use a non-resorbable one, even though absorbable sutures do have their own advantages. With the non-absorbable, we get to see the patient again, and we ensure that the sutures are going to stay in place and they don't get absorbed faster than the wound healing. Okay. So, for example, let's take an example over here. Today, we have a non-resorbable 30 silk suture material that is present. If we focus on the details, we have this reverse cutting. Now, as we can see the cross section of this, reverse cutting ensures that we don't tear into the material of the tissue. That is the reason why this is going to basically help us in going through the tissue and not tearing it. So reverse cutting is basically why we use the reverse cutting. This is the cross section of the needle. Now 3/8 is the circle. Why 3/8? Because we have oral tissue, oral cavity is a smaller space to work in. So we don't want a really huge needle. That is the reason why we take 3/8 circle. So we have, quite a adjusted kind of feel to work in. So now let's begin with the surgical procedure. One tip I would like to give you is that whenever we remove the needle, we have to make sure that we hold the needle, the tip of the needle holder at the 2/3 from the starting point. Okay, this ensures that we don't interfere with the the suturing procedure, and this ensures a very good grip. And one more tip that I would like to give as a clinician is that whenever we remove the suture from the, before we begin with the procedure, we can always make sure that we have a cotton which is dipped in normal saline, or if you want, we can also use a betadine gargle for that matter. And we need to make sure that we wet this entire suture material. Okay, we can also do one thing. We can use the patient's blood, the non-inflamed blood, the fresh blood, and we can also clean this entire material before we begin with the surgical suturing procedure. Okay. So after we have placed the needle holder tip on the needle, now this is the body of the needle. This is the tip. If you can see the cross section, we'll be able to understand that this has a reverse cutting kind of a cross section. And we have the gauge where the entire suture material is attached to the needle. So there is one more principle that I would like to focus on. Whenever we place the suturing, whenever we start the suturing, we have to ensure that this tip is exactly 90 degrees from the starting point, wherever we are going to insert the needle. So basically what I mean to say is that it has to be perpendicular to the surface that we are going to insert it in. Okay. So this ensures that we don't tear it, rather we go more focused. Now, I will begin with one of the most simplest technique that we all can apply, that is simple interrupted sutures. For example, if we have a lip laceration or a direct cut on the lip, or for example, we have it on the floor of the mouth or the tongue of, let's take an example of flap surgical procedure. After the entire flap surgical procedure is done, we are going to close and approximate both the buccal as well as the lingual or the palatal surfaces, that is the gingiva on the buccal um, and the palatal or the lingual aspect. So as I would like to reorient again, this is the buccal aspect, this is the distal aspect. So we mostly we start from the distal and we go to the mesial aspect. So let's begin first with the simple interrupted suture. Now I'll be inserting it on the buccal aspect. If you are comfortable, you can use a tissue forceps to hold the tissue. But personally, I don't use it because the tissue that we deal with is extremely fragile. So there are chances that we might, inadvertently tear into the tissue because of the tissue forceps. And to have a very good access, we obviously use the either for retraction of the cheek or the tongue, or for the reflection, we use the mirror in the other non-working hand. So let's assume that we are not using the tissue forceps for now. I would like to draw your attention towards the suturing procedure that I will be beginning. Now, let's say that this is the wound, or this is the area where the incision is made. So exactly 3 millimeters from here, obviously we cannot measure it, but after a point of time, you understand where to insert the entire needle tip. So 3 millimeters from the incision line on the buccal aspect, I will be inserting exactly perpendicular to the surface. I'll be inserting the suture needle. Okay. Let's say we are going over here. Okay. Okay. Then I'm going to release it. I'm going to obviously pay attention to the end of my suture thread, because we don't want it to lose into the tissue. Then I'm going to remove it from the incision. Okay, let's take it whole, completely outside. Yeah, that's it. This much is enough. Again, I'm going to reorient my needle holder and the needle. Then I will be going inside again on the lingual or the palatal aspect. Okay, and then from here, okay, approximately, let's say 3 mm from here. We have to make sure that we don't entangle it. Okay. So as we can see, 3 millimeters on the buccal aspect from the incision line and 3 millimeters on the palatal aspect from the incision line. Okay, we have the needle over here. Now, I would like to draw your attention to the knot that I'm going to place. This one is the surgical knot or the surgeon's knot. Surgeon's knot ensures that it doesn't, untangle, or it doesn't, the suture stays in its place and the knot stays in its place throughout the entire duration of the healing of the wound. So we are going to take the needle holder, rotate this entire needle holder clockwise. You have to understand clockwise and anti-clockwise before we begin. Twice. Okay. Then I'm going to take this thread, the distal aspect of the thread, and I'm not going to place it on the wound. I'm going to place it over here. This is my first knot. This was the first knot, which was clockwise. Okay. I'm going to put a pressure. Fine. A lot of clinicians put one clockwise and one anti-clockwise, but to ensure that it really stays in its place, I use two clockwise. Once again, I'm going to turn it clockwise, take the distal aspect of it, tie it. Okay, it's tight, but it shouldn't be too tight. We don't want to break it. Now I'll be going anti-clockwise. Okay, so this was clockwise. Now I'll be going like this. So let's do it the other way around. Why are we doing it anti-clockwise? Because we want to make sure that it stays in place, you know. Okay, that's it. So we have our first suture that is made. Now I'm going to hold both the ends together. We don't want to leave it too away from it, but whenever we have a resorbable suture, we place it at least 2 millimeters from the knot, the tip of the surgical scissors. But now, since this is non-resorbable, I'm going to take it a little distal from it, and we are going to leave at least 3 to 4 millimeters of strand so that we can remove it. Okay, that's it. Now I've cut it. Beautiful sutures. Okay. Once again, I would like to repeat it for your reference. This is a very simple kind of a suturing technique which can be done in almost any cases where we want to achieve healing. Whenever we place the second suture, in case if, for example, let's say that this is a completely edentulous patch and we don't have any teeth for referencing. So let's say that you are assuming that a teeth is present over here, a tooth is present over here, and exactly at least 6 to 7 millimeters or say 10 millimeters, 7 to 8 millimeters will be fine. We place the other suture exactly at the same spot, 2 to 3 millimeters away from the incision. Okay. Now, once you become expert, you can, instead of taking it out from the incision line, we can do one thing is that we can just go inside, orient our needle tip on the lingual or the palatal aspect and directly come out from the other side. Okay. We obviously want to make sure that we don't lose the tip of the needle inside the tissue and create more problems in the wound. So very beautifully we have come out on the other side. Okay, we have to ensure that, as I said before, we have to ensure that the wound is completely clean inside the incision, or the flaps are completely totally clean inside. We don't have to worry about the distal aspect till we keep it at least an inch outside or more than an inch, because we don't want the distal end of it to get lost inside the incision or the wound, and then we start doing the whole procedure again. So again, once again, I'll be repeating my surgeon's knot. One clockwise, the distal aspect. Okay. Now, since this is dry, my suture is getting a little tangled. That is the reason why in the beginning I said that we need to wet the entire strand of it with either normal saline, betadine, or even the patient's fresh blood. Once again, clockwise. Okay, 2 knots. We need to make sure that the tissue is not that fragile. If it is very fragile, then we need to go for the absorbable or the resorbable suture. Then this is the final knot, which is going to ensure that it doesn't come out before the healing time. This is the anti-clockwise orientation of the suturing. Okay. This is how we ensure that. For your reference, I'm keeping this extra distal, end of the suture material, but we can keep, after once you get the hang of it, we can keep at least, say, 2-3 centimeters max of the distal aspect of the suture material, and then we cut exactly 3 to 4 millimeters. Once you get oriented, we get a hang of what exactly we are doing. Now one more, this is the simple interrupted suture. Another technique that I would like to demonstrate today is the figure of 8. Now figure of 8 we can use in oral surgery procedures. Whenever there is an extraction socket that is present and we want to do, say, socket preservation, we want to put in some kind of a graft material or something, so we can go ahead and do our figure of 8 over there. Whenever, for example, this is a completely entire edentulous area, fresh extraction socket. Once again, I'll be orienting my needle, tip of the needle on the buccal aspect, same exactly as here. We'll be inserting it on the buccal aspect, at least 3 millimeters from the incision or the papilla, we can say. Insert it inside, get it outside on the other aspect, the lingual or the palatal. Release it, take it out from this side. So we are inserting from buccal to palatal. Okay, this time I will show you how to do it with a smaller remaining strand. Obviously, as I said, we are supposed to ensure that we don't lose this strand wherever we are going to tie our knots. We are not supposed to lose it inside, because we are not going to hurt the patient again and again by reinserting our needle tip. Okay. Now this is the, I would like to reorient you again. This is the buccal aspect, this is the distal aspect, and this is the lingual or the palatal aspect, and this is the mesial aspect. So we have the needle inserted on the buccal, coming out through the palatal. Now we are going to cross it. How are we going to cross it? Orient it once in your mind. This is how the wound is present. This is the socket that is present. And we are going to cross it. And this is where I'm going to place my next, insertion point. Okay. Exactly over here, 3 mm from this. Okay. Okay. We have to make sure I'll be showing. Okay. So this is how we see half a cross. Okay. Now, how do we want our cross to be? This is how we have inserted it. We've inserted, reinserted over here. And then we want it to end over here. Okay. Sometimes you might not get an orientation, but you're just supposed to imagine a cross. And that is how you can reorient yourself once again. Okay. Now I'm going to reinsert into this. This is how it has come out. Okay. Then finally, this is how we want it to end. So once again, surgeon's knot, clockwise. We have to ensure that nothing is loose over here, because we want to make sure that the plug stays in its position. We're not supposed to tighten it. We don't want to necrose the tissue. So it has to be firm, not too light. This knot, not too lightly tight, not too tight as well. Again, once again, another clockwise turn. Okay. It's to be a firm knot. Okay. Then anti-clockwise, the last one. Another tip that we have, sometimes people tend to open up the needle, the blades of the needle holder. So you might, entangle the entire suture material. So rather, best is to make sure that whenever you are tying the knot, you have to close it. And then you start with the anti-clockwise. You open it again. And then we have the final knot in position. Once again, since this is non-resorbable material, I'll be cutting it 3 to 4 millimeters from the distal from the knot. You have to make sure that both the strands are equal. Not one strand will be 2 millimeters, other will be 3 millimeters. We have to make sure that we cut it exactly at 3 to 4 millimeter mark. And this is how we are going to see it. Now we can imagine that there is a say gel foam that is placed, or we have placed certain graft material inside to ensure that the healing is much more faster. So these are the two very basic suturing techniques that we have studied today. There's something called as mattress suture also. Now, what is exactly mattress suture and why do we need this? Now, these two techniques that I mentioned are simple interrupted and figure of eight. These can be done in most of the clinical situations, but in case if the wound is much wider, for example, if it is open like this and we really want to approximate it a little more closer, that is when we go for mattress sutures. Mattress sutures, yes, they are absolutely helpful, but these are quite time consuming, and by the end of the surgery the patient is quite tired, to be honest, keeping his or her mouth open. So these are very simple. The two techniques that I mentioned, these are much more simple and much more faster. But in case if it is a gaping suture, it's a little larger suture, incision that is present, or the wound that is present, you can definitely go for mattress suture. So now I would like to demonstrate a vertical mattress suture. Now this is how the wound is open. Let's assume. This is a little unique. That is why I'm mentioning the vertical mattress suture. Instead of going 2 to 3 millimeters from the incision line or the wound, open wound, we will be going at least 4 to 6 millimeters over here on the buccal aspect. Okay, so I'll be inserting it like this. Now, since we have got a hang of it, now this needle, the body of the needle is smaller. So rather than taking a direct jump on this side, I will be getting my needle, tip of the needle on the from the wound or the incision. Okay. Once again, I will be going through the incision or the wound. And on the other aspect, that is the palatal aspect or the lingual aspect, let's say lingual aspect, once again, I'll be coming out 4 to 6 millimeters away from the incision line. Okay. If you can compare it with the previous ones, this distance is much more larger. Okay, because we want uh, two sutures to be placed exactly on the same orientation plane. That is the reason why we began the first pair from 4 to 6 millimeters away from the incision line. Okay. Now, this is the tricky part to remember. I'll be reorienting my needle once again. Now I will be going from the lingual aspect, and this time let's say that we will be inserting exactly on the middle or the mid section of this orientation line, if you can say, an imaginary line from the incision point to the insertion or the point where the suture just came out from. On the lingual aspect, we will be inserting it like this. Now you can directly go into because this is a smaller distance, so we can directly come out, instead of coming out from the incision line, we can directly come out on the other aspect. This is how we can see it. Okay. And finally, we are going to tie this again as a surgeon's knot. And this is how we are going to place the knot, first knot. Once again, clockwise. Going to place it. And then the last knot, the third knot, will be anti-clockwise. Okay. We don't want to make a clump of suture material at the knot end, but obviously since these are very minor diameter materials, we can ensure that we have good amount of locking, if you can say, of the knot. Once again, I will be cutting it 3 to 4 millimeters away from the knot. And this is how we can see it. It has to be very organized. Whenever we suture, we have to make sure that it is exactly mirror image on both the sides. We don't want this point to come, this distance or this suture material to be like, say, 4 millimeters. This is going to be 5 millimeters. We have to make sure that there is some sort of symmetry. And it is not because, obviously, this is not a canvas for us, but it ensures that the healing is proper. See, whenever we perform any surgery, irrespective of the age and the gender and the condition of the patient, debilitating condition or the age of the patient, we always have to remember that body heals itself, repairs itself beautifully. We are just assisting the healing procedure by with the help of grafts and sutures and gel foam, etc. So we always have to remember that any step of the procedure that we perform, right from the diagnosis to the suturing and the maintenance phases of the patient, we have to make sure that the entire procedure is done diligently and absolutely carefully. We have to make sure that everything that we use, right from the suture material, the grafts, everything has to be sterilized, because wound healing is ensured only when the surgical site that we have treated is absolutely sterile. Obviously, 100% sterilization cannot be achieved, but we need to make sure that this entire site of surgery or the site of intervention, whether it be in implants or extraction socket or flap surgeries, etc., we have to make sure that the area is clean, clear, visible, and there is no other foreign object that is present before we begin with the suturing procedure. And this is how we complete our suturing techniques. Now, there are a lot of other suturing techniques available as well, like for example, simple continuous or continuous loops, horizontal matrices, etc. Those are something that can be studied and they can be performed. But the thing with the continuous sutures, there are a lot of limitations for it. For example, in the continuous sutures, there is only one knot that is present, or you can say two knots, but it is a huge span. We start right from here. Uh, this technique, okay, fine. So I will be revising the vertical mattress suture once again. Okay. This is a little complicated or a little complicated to understand at first, but this is very simple once you understand the design of it. You can just look at the entire procedure that I have done in previously, and our goal is to basically, this is the buckle aspect. Our goal is to basically end up over here, tying our knot over here. This is the incision or the wound that is present. So let's begin again. We will be going on the buccal aspect 4 to 6 millimeters from the incision line. Let's orient it over here. This is, say, 6 millimeters from the incision line on the buccal aspect of the wound. Okay. I'll be coming out from the wound or the incision line. Okay. My needle point has come out. This is the wound that is present, the incision that is present. Okay. Then once again, I will be, now instead of going from here, from lingual coming out, I can go from the incision itself, come out at least 6 millimeters. Since I've inserted it at the 6 millimeters mark on the buccal side, I will be going 6 millimeters from the incision to the lingual aspect. Okay. Let us say this is 6 millimeters from the lingual aspect. Now my needle has come out once I've inserted it from the incision point on the palatal or the lingual aspect. This is over here to make sure that it is absolutely clear. Okay, as we can see, 6 millimeters from the incision line to the buccal aspect. On the buccal aspect, I've inserted once. I took out my needle point from the incision. I reinserted it from the incision once again, and I oriented my needle tip 6 millimeters away from the incision line, and I came out. This is how it is going to look. Now I will again insert my needle tip, but this time I'm not going on buccal aspect. This time I am going on the lingual aspect. We can say let's insert this point of insertion 2 to 3 millimeters from the point where I came out on the lingual aspect. So let's say over here, since this was 6 millimeters from the incision line, I'm going exactly at the 3 millimeters mark, exactly at the middle. Okay, I'm not going to come out from the incision line, rather, because it is a smaller gap. So I'm going to directly orient the tip on the buccal aspect. So this is exactly reverse of what I did before. The insertion was from buccal to palatal. Now it is from the palatal to buccal. Okay. This is how we have come out. So we have ensured that the palatal side is already secured. Now we need to tie the knot on the buccal aspect, because we always want our knots to come on the buccal aspect. Obviously, we never let this knot to come on the lingual or the palatal aspect. So again, clockwise, I'm making sure that this is locked. Okay. This is how we are going to. Another one. I'm locking it again. Okay, so my clockwise, 2 turns clockwise are done. Now I'm doing the last knot, which is going to ensure that it stays in place. Then I will be closing this. And this is how we end our vertical mattress suture. Now, this is especially useful when we can say in implant procedures. Okay, I'll be cutting it from here. 3 to 4 millimeters from here. Now let us imagine that there is an implant that is placed over here. We don't want to interfere with the collar of the gingiva. That is the reason why we can go with the vertical mattress sutures rather than the simple interrupted, because obviously since these suture insertion points and releasing points are quite much far away from the papilla or the collar of the future collar of the implant. That is the reason why we can choose the vertical vertical mattress suturing procedure over here. So with this, I would like to end my session about the suturing techniques. Thank you so much. Have a nice day.
Thank you very much, ma'am, for the insightful various suturing techniques. I think everyone have benefited out of this, and various clinicians also out there now will be aware as to what suturing technique they are supposed to be using, especially when you had mentioned even about the implants. Now I think they'll be able to use them very well. So thank you very much. It was a great pleasure having you over here. Thank you very much, ma'am. Just take a short break. We'll resume in 5 minutes. So now we'll be temporizing the 4 incisors that we have done crown cutting for, and we'll be using bisacrylate material to give temporary restorations. We've already made the putty index and kept, and Dr. Raj over here will be helping us. We'll be doing spot bonding of all the 4 crowns. We'll show the entire procedure to you. Over to sir.
Yeah, I'm very thankful to you, madam, for coming over on a short notice. And it was a very good experience for all the learners and all our students to learn, because we train people in our department for periapical surgeries, periarticular surgeries. And suturing is a very, very important step, as you emphasized it. So just give a small reaction to how you felt about it. Thank you.
Thank you so much, sir. Actually, I'm really fortunate. I feel that I've got this opportunity to train so many students. We all are lifelong learners, as I always believe. So, whether we are UG, PG, or practitioners practicing since many years, I think the learning process never ends. And I'm genuinely grateful to Bhad madam for inviting me here, Abrar sir for giving me this wonderful opportunity to interact with so many people out there. I hope to get more opportunities like these and come forward with whatever small little experiences I've got and learn even more from others. And I would like to thank you all once again for participating today. Thank you, sir.
Thank you so much, Dr. Resham Pakmode. And back to our business again. So if you can see the disc, it has milled out all the crowns that we are designing. I need to open it up. This is Allen key and a star-shaped screw here, screwdriver here. It has been tightened with the three crowns inside, which we have made. Acting against the blue background. You can see all the 4 crowns, those have been milled. We are going to separate them. If you can see, it has been held by 3 stubs from 3 sides, and then the milling has happened. Okay, now we carry it to a sintering furnace and drop it into the furnace. Actual plan was to sinter it completely and do cementation today. However, because of the time constraint, if we start it right now, it's going to take 3.5 hours. So it goes much beyond the working hours here. I will post the picture online after cementation. Okay. By that time, we are going to demonstrate with a putty index about temporization. आप डाल दीजिए इसको. स्क्रूज अंदर डाले हैं, स्क्रूज अंदर ही रखे हैं, घूमने नीचे आप. समझ गया मैं बाद में. हाँ, तो अंदर आपका वो भी ऊपर रख दिया, आप डाल दीजिए उसमें. Mr. Hoshiyar Singh will start the process for sintering now. Yeah, we need to cut. Eroder chalega?
Yes.
हाँ. Aditi, please help him out. Be careful about yourself. आपका की भी अंदर डाल दिया हूँ, इसके घूमना नहीं चाहिए. We'll separate the stub, isolate the crown. Resham. क्या करो? सेपरेटिंग मीडिया. Scope. Live. We have to go live. Open. Okay. Which ma'am? Okay. सर आपका हाथ देखो. हाँ, हाथ दिख रहा है. What are we at?
We have applied a thin layer of bonding agent in the center of tooth. We are spot bonding the temporary.
Okay. Spot bonding. Not coating a uniform layer, right? So currently we are spot bonding the temporaries, meaning we use certain areas of the tooth preparation to bond temporarily, so that we don't have a uniform bonding there. Sir has used an applicator tip in the bonding agent in certain areas, followed by curing.
Followed by temporization and then curing
And
along with
you
bisacrylate.
using the
Bisacrylate.
bisacrylate now. Okay. Protem material bisacrylate. Let's start. You don't want that 3D printed stent, no?
No.
No. You are comfortable with this because you can cure that through the. You can't cure it.
This also.
Autopolymerizing. Okay, done. Focus on this and the butty. अंदर focus करो आप. Show it to the camera, please. You can see with the auto mixing gun, sir is no. That camera you show. That camera you show. Big camera. Now it's being inserted. The putty is being inserted. We all can see it's a beautiful look there for the temporaries. Can you retract a little bit? Yes. See slight excess flow in the cervical area. Otherwise, the temporaries have come out beautiful. We have, sir is removing the excess. Keep the head stable. Beautiful. जबरदस्त कर रहा है सही कह ना इसमें ब्यूटीफुल लुकिंग सो गुड simultaneously we are separating all ceramic crowns from the stubs, removing it out of the disc and making them ready for sintering process. If we plan the session to be prolonged today by 3 hours, we can directly cement it today itself in the evening. Anyways, it's going to be ready by evening today. What time is it now? 3:30. So by 6:30 or 7 o'clock, we can cement it permanently. We did not need this temporary, but the program is live and there's so many learners. So we are demonstrating use of temporization simultaneously. Sir, head should be stable position. Huh? Yahi. हाँ. चलो. Maybe. So the excess flash is being removed. Because a bowl to keep the crowns inside the furnace for centering. It's like our crucible refractory material, and these are beads. किस चीज का beads है?
Glass
Same.
ceramic. This is glass ceramic.
Glass ceramic. Glass ceramic beads are here for passage of the heat. Now we are putting all of them together. We put the glass beads on the top of which we have placed our milled crowns. These are going to go inside the furnace now. Here are the settings of the temperature and the time.
to this.
Yeah.
Let's start.
Start. We are pressing start button now. दूर से दबाना पड़ता है क्या? Sir, sir, hello, sir. Hello, sir. चालू आहे तुमचं? Okay.
मतलब अभी जो स्टार्ट कर दिया तुमने. ओके. ओके. ये 9 आवर्स का साइकिल है. ठीक है. और इसमें हम लोग जरकोनिया डालते हैं 9 आवर्स के लिए. इसमें 2 आवर्स इसका होता है पोस्ट प्रोसेसिंग टाइम, जिसमें वो सिर्फ ड्राई होता है जरकोनिया. और 7 आवर्स इसके लिए होता है बेक होने के लिए. जरकोनिया आप जितना मतलब ज्यादा उसमें डालोगे, सिंटरिंग में डालोगे, उतना उसकी स्ट्रेंथ ज्यादा होती है और शेड आपको एकदम परफेक्ट आता है. अगर जरकोनिया कभी फास्ट सिंटरेट करोगे तो उसमें शेड्स नहीं आते, उसकी स्ट्रेंथ भी हमेशा कम रहती है. इसलिए ऑलवेज जरकोनिया एटलीस्ट 9 to 10 आवर्स पुट ऑन सिंटरिंग.
So currently what we're doing over here is, this is dual cure material. So we're light curing it. It's auto polymerizing definitely, but there's dual cure as well. So we're light curing it as well. And it will also help in good bonding to the tooth structure. We're checking the final adjustments. Nine.
तैयारी है उदय जी. हाँ सर, you yeah, focus it. Wait, I'll focus it. Wait, I'll focus. Now it is focused. As all of you can see that we have temporized it. We have temporized it for the purpose of demonstration. Basically, our ceramic crowns are going to be ready by 6:30 today in the evening. So we can loot it today in the evening, or we can do it tomorrow, day after tomorrow also, as tomorrow is a holiday for the institution. So this is a temporary. This is the look. This is a design that we have anticipated in the pre-operative. As you see, this index is obtained from a 3D printing of virtually designed restoration on the fractured teeth. So the permanents which are going to come as per our design after the tooth preparation. So they're going to be much better in the contours and design. Okay. So we are in the final stage of finishing it. Please continue finishing and conclude. Concluding remarks किशोर सर को देने को बोल देता हूँ. किशोर सर.
Am I audible? Okay. So on behalf of Government Dental College and Hospital, Department of Consultative Dentistry and Endodontics, I thanks all the audience, the faculties, the UG student, the PG student, the general practitioners, and hope that you had a good learning experience with us. Anything that you want to share, we have already still live. You can put your remarks, suggestions, any critics in a good way that will grow you and us academically are totally welcome. So I request everybody, and we will be in future also, we'll be conducting such a programs maybe in the next coming months. And please also give inputs if you want any particular program or any particular procedure to be shown by us. So we'll be highly appreciate that also. So I thank on behalf of Government Dental College and Hospital Mumbai to everyone. Thanks, and hope you have everybody have a nice time, had a nice time today. Wishing you all the happy Independence Day in advance. And with this, I conclude this session and declare this session to be over us. Thank you, everyone. Thank you. Thank you.